Okay, good morning. I do apologise for the late start of the meeting. We've been waiting for some people to arrive. My name's Brenda Jones, and I'm the chair of the Health Overview Select Committee. The meeting. This meeting is being held in person at County Hall and is also being streamed live on the County Council's YouTube channel. A fire alarm test is not expected during the meeting. If the alarms sound, we must evacuate County Hall. In the event of an emergency, please make your way to the nearest exit and meet at the muster point located in the main car park. Under the Council's protocol on the use of media equipment at meetings held in public, this meeting may be filmed, recorded or photographed. Anyone wishing to do so must inform me and ensure that it's done in a way that's clearly visible to everyone present. The wishes of any individual not to be recorded or filmed must be appropriately respected. So firstly, I'd like to receive apologies for absence. So Megan, can you let us know, please?
Thank you, Chair. I have apologies today from Councillor Lucy Shires, Councillor Richard Price and Councillor Jeanette McMullen.
Thanks very much. Now I'm moving on to the... Oh, I beg your pardon.
Sorry, Chairman, I must apologise in advance to the committee because I have to leave about 11 o'clock for another council meeting.
Thanks for letting me know. Thank you. Okay, moving on to the minutes of the meeting on the 15th of January, I'd like to propose a couple of amendments before I ask the committee for their agreement. Firstly, under bullet point 9, section 6.4, it should state that Dr. Swords replied that the Norfolk and Norwich University Hospital were involved in a project to understand and reduce barriers to include a wider range of patient cohorts in research studies, such as people over 80, those who lack capacity, and those approaching the end of their life who have traditionally been excluded from drug and other trials. In section 7.3, where it states that the Norfolk Medicine Support Service was commissioned in 2023, the correct date is 2003. And finally, a point of clarification was also made under section 5.2, bullet point 4. It was confirmed that discussions with the ICB regarding the removal of service were hoped to conclude with an agreed way forward by the end of March 2026, rather as stated at the previous meeting.
Of the conversation and debate today.
Thanks very much. Thanks for letting us know. Updates from the Chair. There are none. So we are, because of the absence of some speakers, to look at page 40 on your agendas, which is the strategic review of outreach services. Can I welcome representatives from the Norfolk and Waveney Integrated Care Board, Shelley Ames, Tracy...
The full review to understand what we should do for the future. And particularly look at what good looks like in line with some of the new national guidance that's coming out, and particularly a couple of days ago, the neighbourhood health
background with lots of experience working in general practice with including vulnerable communities, and I'm a nationalist that we reviewed as part of this was our Inclusion Health Locally Enhanced Service, our Wellness on Wheels bus, and our Inclusion asylum seeker healthcare team. Our focus was on these populations that were those contracts. We realised that we hadn't received much kind of service user engagement. Some of the data was missing, some of the data wasn't even collected, and the outcomes that we're looking for, we weren't actually capturing those, so there was a great need to do that. So we undertook an assessment of those services using the Health Equality Assessment tool to see how they were achieving the outcomes we hoped they would. We also engaged our research and evaluation team to take a thorough look of national evidence, where good practice was, and they were able to establish what good ought to people and make reasonable adjustments. So Shelley's just going to say what next steps are, and I know you've got a lot more detail in your paper, and we're very happy to answer questions on any of those.
Thanks for that.
Hi everybody, I'm Shelley Ames. I'm the Head of Health Inequalities and Voluntary Sector Partnering currently for the Norfolk and Waveney ICB. And I'm the commissioning lead for this review. As Tracy said, this is quite early in the commissioning cycle, so we're really focusing on population need and what the evidence base tells us for now. The next phase, so we're not making any decisions yet about what we commission. What we're going to do next is a really thorough programme of public and stakeholder engagement, which we're going to kick off after the pre-election period and deliver over the summer. And we're going to do that in partnership with our colleagues in Healthwatch, in Norfolk, because we are looking at Suffolk for this review too. We also have a programme called Community Voices, which is working through trusted communicators in our voluntary sector who work with these really vulnerable cohorts. And we'll be working really closely with those charities to make sure that we get those voices represented in our decision making. So we still have some way to go in terms of the decision making process. We have those early findings that you have in your paper today. We'll be conducting the engagement over the summer months, and we're aiming to conclude those early in the autumn so that we can shape our options for what we commission from the 1st of April 2027. So all of the services that are included in your paper today will continue until the 1st of April in their current guise. I'm really happy to take any questions. Thank you.
Thank you very much. Can I ask members, please, if you have any questions, to raise your hands and to come through me. If you have additional questions that you would like to ask, please would you raise your hands again? So everybody will get one question, depending on the timing, because we have a very busy agenda today. So who's... Lucy Galvin, Councillor Galvin, please.
Can't currently be demonstrated due to limited or inconsistent. So I was going to ask, how can you commission when you acknowledge that? So I think that's dealt with. And you do emphasise in the report quite often principles and national frameworks, but there's a complete absence of any costed delivery plan, timeline or performance metrics. So I'd like to sort of know exactly when you will produce that detailed implementation plan showing how the outreach models will reduce health inequalities. It sounds as if that is something you're working towards. I've got a potential recommendation around that. I'd like to know a more detailed question from the report then. What assurance you can give that GP practices receiving inclusion health funding, LES funding, have actually delivered the requirements, like clinical lead, trauma-informed training, longer appointments, proactive follow-up? And why does the report show no audit evidence that those activities took place? And why also does the review rely on internal NHS frameworks rather than inclusion health evidence and best practice from, for example, the Faculty for Homeless and Inclusion Health? So, sorry, apologies. I'd like to know when that external evidence base will be explicitly integrated into it. But firstly, how we can see, because you can say GPs should be delivering it, should be mainstream, that's the message I'm getting. But the message I hear is it's very difficult. GPs can deliver it, yeah, but they haven't got time. It's time they need, it's not the skills. And also these are areas of specialism, like oncology or any other specialism. Inclusion health is something that requires specialist treatment. So yeah, that's a slightly detailed question, but do you need clarification on any of that to answer it? Or?
I'll try to break some of it down and answer bits of it if I can and chunk it up. So I think the Inclusion Health Locally Enhanced Service is a service that is for our GP practice, and there are two elements of that. So one element is making a GP practice safe for inclusion health groups, and the second element of that, which depends on population health needs currently, so it's currently as it stands now, provides outreach support for communities. Now, returns are made currently in this provision to the Integrated Care Board. So case studies are submitted, numbers of outreach clinics are submitted, and actually we do have some data on where populations are as a result of that work. So there is some data that's collected, but it's not sort of the data sets that we really want. So in the future, the Commission Service will really have that absolute outcomes focused data. That's what we want to do. So that hopefully covers that element for you. The second element about the national best practice, the service specifications currently absolutely do include the faculty standards. They're referenced in the service specification that practice currently work with, and they will be in future. I think we have done a huge research evaluation for our research team. We've looked at all the national recommendations, ways of working and models, and we can provide that information of that evaluation if you'd like to see it at the HOS committee, because it has been done, and we will be using that as our gold standard and our principles going forward. That's probably answered to your questions. If there was anything else, do ask, if that's okay with the chair.
Could you be brief, Lucy?
I think I can come back to it at recommendation stage, but I've got a potential recommendation there. But just if you park that for later.
Okay, thanks very much. Pallavi, please.
Thank you, Chair. Thank you for doing this piece of work. I think it's laid bare the challenge before you. It's huge, and you're dealing with a very tricky population, which is hard to measure, hard to reach, which is the whole point of the exercise, of course. I suppose my comment really is, I come from a GP background. I'm not a contractor anymore, so I've got no conflict of interest at all. But I want to ask, when you crunch the numbers, I would plead that you check to see which the most accessible as well as financially sensible model would be. And it's not always a new model that kind of does its thing. The other thing I'd like you to consider in your work is whether it's actually cheaper and better to provide transport for individuals who may be scattered right around Norfolk, to take them to a place which has all the facilities to do a one-stop health checkup, promotion, education, whatever else, with translation facilities and all the rest of it, so that they get what they need at the time. And then to have close liaison with substance misuse providers as well, and mental health. Thank you.
Thank you, that's really helpful advice, and I think we'll certainly take that on board. I think, as Richard has said, we are moving towards neighbourhood health approaches and population health, so I'm really hopeful, kind of the work that I do working locally in general practice with other NHS providers and with the voluntary sector most importantly, that we will have a really population focus in local communities at a neighbourhood level, and I think some of those kind of advice that you gave us just now will certainly work with those approaches going forward. And I think we're really open, so the next stage of this strategic review is that engagement with stakeholders and those with lived experience, so we're really open about what will work and what, we obviously have to be, have value for money, but we actually want to improve on those health outcomes in the longer term. So thank you, that's really helpful advice.
Thank you. Leslie, please.
Thank you, Chairman. You mentioned that community voices are going to be listened to. Who are these community voices? I mean, I represent Kingsland North and Central, which is an area of deprivation, and particularly about health. In West Norfolk, North Lynn comes top of the life expectancy, not in a good way, in a bad way, both for men and women, and compared to districts nearby. So who will you be talking to? And as a supplementary to that, when are we going to get some action, please?
On the action question first, these services are continuing in the meantime. So this is about what we develop that's more fit for purpose for the future, given the policy changes around neighbourhood health, the changing evidence base. But also one of the things in the data it's showing us is that dispersal looks differently. These population groups aren't centred in one part of our Norfolk and Waveney system, as perhaps they might have been previously, and we are seeing the distribution of these inclusion health groups and vulnerable groups more broadly spread across the system, so we need services that can respond to that. In terms of community voices, we have a programme which we have worked with our colleagues in Health Watch on for the last few years, where we work with the voluntary sector, so charities that then have relationships with the communities that we're talking about. We've got 50 plus charities on the framework that we work with within Community Voices, and many of those represent those communities that we are talking about here. So as an example for West Norfolk, we've worked really closely with the Hanseatic Union. We work really closely with housing associations so that we can access those communities that have greater need, etc. So there are quite a large number of charities that we work through, so that through them and through their trusted relationships, we can have conversations with people with lived experience. So that's our plan, to both work through Health Watch, who obviously have enormous reach in terms of their access to communities, but also those charities that work really closely. So in Norwich, that would be the St Martin's type organisations, Magdalene Group for vulnerable women. We've got some really excellent charities in our system that we can partner with on that engagement piece, because they have access that we perhaps don't to the communities that we're talking about.
Just ask, are not local councillors involved in that? Because they're the people that talk to the people. You know, I know housing providers do, but they're very limited to what they do in some areas, because, you know, it's a big undertaking in the work that they do. But I recently had the occasion to help somebody who had mental health problems, I imagine. I think he was a hoarder. And I had to come direct to Adult Social Services and the Housing Department in the borough. And he'd been on the cards, as it were, for a couple of years, but had been totally missed in the latter stages of his problems. And the premises he was living in were being sold. So, you know, nobody could even answer me if he'd been served with a Section 21 notice. So, you know, I knew that because I talked to him, and it was all dealt with. But there are people that are just missed. And although I'm is a town ward, town division, 2 wards, there's quite a big distance between the two in terms of how some of the people live, and I just think these people are missed. But, you know, that's only my overview. I don't know those facts, so I hope the facts come out. Thank you.
We've co-designed the model for community voices with district council officers, so there has been involvement from a district council perspective, but we haven't worked closely with councillors, so we'd really welcome that input. Just in terms of the missing element you raised there, part of the review we've been doing with our research colleague is on something we called missingness. So actually we have a significant amount of missingness from our primary care data, people that aren't registered within primary care. And if we are going to use population health approaches, we need to be cognizant of that missing element of our data and not base all our decisions on that. So we are considering what missingness means for us in terms of this strategic review and how we can encourage people to access services that perhaps have never crossed the threshold of primary care. So we have to think about that element, obviously, as well as the cohort that are already engaged.
Could I ask Alex Stewart, please?
Thanks. Leslie, in response to your question about West Norfolk, one of the things I can assure you is that community voices are very much embedded within the Marmot partnership as well. But they are there, and that's working collectively with a whole range of different organisations, both statutory and non-statutory.
Thanks for that input. Thank you. Stuart, please.
Yeah, thank you, Chair. And my comments and questions are going to very much echo what's come from behind me from Leslie. Top of page 50, where we talk around, or the report talks around the available data, suggesting that actually there are challenges in areas across Norfolk other than urban areas. Whilst I really welcome that, that is somewhat behind the curve to us as councillors who have been sitting on children and adult services, etc., and have been talking about pockets of rural deprivation and isolation for quite some considerable time. So that data, that information across agencies has been talked about for quite a while. In terms of this, the concerning comment or phrase that I had is trusted partners, getting those voices out, because if you speak to the same people time and again, you're likely to get the same input time and again. And if we are saying that we're moving into new areas, like Leslie's been saying, you really need to start engaging the councillors and the communities and the individuals in those areas to get those voices back on those areas. So I guess the comment that I've got is that I'd like some reassurance and maybe from this some drive around, if you're saying there's parts of Norfolk that you have got patchy information around, instead of going to the same trusted partners, reach out and find out that there are partners on the ground in those areas working regularly and start new conversations as well as existing ones. Thank you.
Again, thank you. That's really helpful advice. And we do know that there is that deprivation, those pockets of deprivation within our rural and coastal communities. And we have a framework in the NHS, which is called Core 20+5. It's a clinical framework, but it's actually got core is the most deprived 20% areas, index of observation 1 and 2, and plus is other sort of communities, populations that really have the worst health outcomes. So inclusion health groups are one of those, but for us in Norfolk and in Suffolk, our rural and coastal communities and those pockets of deprivation is another. And we're really keen to work with whoever we can work with to kind of have those conversations and seek those views and gain that data, you know, from those communities, so the picture makes sense and we have the full story. So thank you for that offer, and as part of the engagement we'll certainly look to be doing that.
Thank you. Victoria, please.
Thank you, Chair. I mean, I was going to question the lack of clinical outcomes, but you've sort of answered that and we await that with interest. Also, I would certainly echo what Stuart said about rural and county communities. I'm a coastal elected member, so and I know how much deprivation is scattered around. Two questions really. Are travellers included in this? I don't see much mention of those. I have a great sympathy for travellers and their life expectancy and their educational attainment, etc. The inequality for them. What about GP practice engagement? I'm surprised to see that there are few GP practices, certainly in the level 2, and the fact that the level 1 isn't a legal obligation seems very odd to me. But is there sufficient GP engagement? Thank you.
Yeah, just to reiterate that our Gypsy and traveller communities are certainly part of this and what that means. And we do know that certainly in Kings Lynn and West Norfolk particularly, through the work the borough has done, there's really good relationships with the community in the west of Norfolk, and we're learning lots from that. And certainly we do know where communities have been engaged with a GP practice for a long time, generation after generation will go back again, and we're finding that's the case in our kind of Kings Lynn and West Norfolk area. In respect of engagement with GPs, we have a really good sign up of GPs at Element 1, so being an inclusion almost sort of friendly practice and meeting those standards and having clinical leads. But the element 2, so which has been the outreach element so far, it's been those practices where they've been sort of a kind of a mix of populations where there's been a homeless hostel, for instance, or a gypsy and a traveller hostel, or an asylum seeker continuity hotel. So that's been based on the population health needs. And we've got some GP practices certainly have that learning and sharing from those expert GPs and other healthcare professionals and make it a really kind of a learning approach as well as delivering services and targeting those services where they're needed. So that's all plans and thinking for the future, and we'll be engaging all of those kind of partners within that, stakeholders. They'll have a part to play in the engagement exercise as well.
Before we come back to Councillor Galvin, has anybody got any questions?
Councillors, county councillors, etc., are contacted by residents, and then we're able to signpost people. It works in there. So we empowered the family and the councillors to be able to do that point of contact. That's not to take away from what the services are providing, but it just really bridged that gap. I was wondering, is there a model that's being used elsewhere in the country that you're looking to emulate that works really, really well, that talks more about engagement first and then the trust, etc., comes with it? Are you looking at any other models and linking in with Health Watch around that?
Thank you. So on your first point around the engagement, Alex is here. We're co-designing the engagement at the moment with Health Watch. Health Watch Norfolk and Health Watch Suffolk, as well as some voluntary sector organisations that have expertise. So we can certainly take on board all the comments today around councillor input into that engagement and factor that into the thinking. So we're doing that process at the moment and thinking and getting that expertise from Health Watch about how we go about the engagement. So we very much can take on board all of the comments today around that, and that would be really helpful. In terms of, so the evidence-based review, so we've been, as we mentioned earlier, working with our research and evaluation team, and we've had conversations with other systems as well that have got outreach models. They all manifest differently, and they all have the kind of, or many of the inclusion health services out there are, a lack of kind of impact data. So we quite often have monitoring data in terms of the numbers of people accessing services, but a little less about the impact. And that's been a common find of the evidence review so far. But we have served that review. We are going to publish that review. Because there is really helpful information in that to inform primary care and other services when it comes to working with particularly our inclusion health cohort. So we will be making that, it's just getting polished off, but we will be making that publicly available on our website so councillors and others will be able to see it.
Thank you. Paul, please.
Thank you. This is quite a broad thing. Data is everything. Actually speaking to the right people. And as Stuart and other people have said, it's getting outreaches to find out from the source themselves, what is needed. But I was just wondering, have you got in place or commissioning use of more AI to assist you in the directions? I always thought I was going to be against that as rely on it, but it can be a useful tool. At the council here, we've commissioned for adult social services specialists who are able to crunch data so that we can actually predict at an early time the different demographics and the different type of people who are going to be in 10, 15 years' time. So is that a tool that the Integrated Care Board are, bringing in, not that being the main thing, which what I would hate to see, but as an assistant, it can be very useful.
I think, Richard might want to help with this a little bit, but I think we become a Norfolk and Suffolk ICB, our approach is very much on population health, and we do have a population health improvement plan, and absolutely as part of that we do population segmentation and risk stratification, and we have ways of looking and working.
I think you've covered well. It might be an area that the HOSC is interested in hearing more about in the future, because actually we are doing a huge amount of work actually across both ICBs with coming together around how we can have a much stronger that linked data set, and how we then use that, as colleagues have just said, to really focus down on our intern work nationally, support on that as well. So if colleagues are into that, might be something, Chair, that we come back to with our lead in that area who can talk for hours on it.
Committee will look forward to, I'm sure. Thanks very much. Claire Galvin.
Thank you. I wanted to just record that we did ask to look at the WOW bus. I don't think that's been mentioned, but this is partly as a result of that, I believe. It was on our work programme, so I don't think this should replace that look, but I think this was originally offered as initial work for that, if I can just record that. So I think it's a start on that. The report does use a lot of aspirational language. Financially quite a significant commitment of resources, and quite big promises were made for the WOW bus. There isn't really much evidence around it, and there are mixed signals in the report. It's criticised. It says it has no consistent core officer, no data, no follow-up. There's not really patient identifiable follow-up of any kind. It's not clear what it's supposed to do, and it looks like it's out of operation. It's not clear what it's supposed to do, and it looks like it's out of operation since the bus is presented as flawed and unmeasurable. But then it's also defended as beneficial, sort of within the same report. It's a bit internally contradictory, really, to look at, because I have her and people don't know where it is. So I'd like to sort of just drill into that and ask you about if there's going to be a proper evaluation of the effectiveness of the WOW bus. You mentioned 87 health checks in there, 82 to 87 health checks, but there's no data on the findings because no patient identifiable data was collected. So it's difficult to track any improved health outcomes. You can't show if the checks did anything at all. Evidence of longer appointments, no audit trail, no evidence of follow-up. So we wanted this report to really drill into this area, and thank you for the beginning of it. But I would say it's really only a beginning, and there's a lot of jargon, a lot of aspiration, and then some clear directions of travel put in there without substantiation. So I'd ask for a report that's more fact-based and less of, aspirational. I know you have to speak in corporate speak and there's a language, but there are people out there and these are the people that have the least help. And we know what helps them. So yeah, sorry, I'll come to a conclusion. But the reason I took a bit longer was because we have waited a long time to look at the WOW bus. And this is a report that's supposed to start to unpick that. So I think we need to focus a bit on that here. So my question is what...
So we commission the estate for the bus. We commission a bus and by our public health colleagues. Now, obviously, with Tracy is a much better versed than I am in the history of the bus and where it ought to get vaccinations out into communities. And we obviously have different models now for getting COVID and flu vaccination out into communities. So the purpose of the bus has changed. It's changed over recent years. We have tried to maximise the use of the bus in that time frame, and we've tested lots of different things within that frame of time, health checks being one of them. But we haven't yet committed to a solid core offer on the bus. So we've had lots and lots of different test and learn activities that have happened. We've had women's health champions on the bus. We've had vaccinations as a core on the bus. We've done work with our dentistry teams, with our smoke-free services. But we do now need to settle on actually what is its purpose moving forward. It needs a really clear purpose. So there's some of the reasons behind why the data hasn't existed to date. And we are absolutely clear on where we need to move to if it's going to continue to be delivered in the future so that we can demonstrate value for money for the bus.
Could I just check that I got something right there?
Excuse me, Lucy. No, I'm sorry. I think you've had a lot of opportunity to ask questions and I think they've been answered. We've got a huge agenda today, so I'm sorry to shut you down, but no.
When would I be able to ask those questions? I think they're quite important for Inclusion Health.
Hold on a second.
Will it come back? Something's been raised there that's quite concerning.
Okay, please will you make it brief?
Yeah, thank you. I'm happy to send the questions in if that's easier. I don't want to... I think Inclusion Health is really important. It is an important topic. So if we're going to come back to this, then I'm happy to park it to then.
Just hold on a second. Richard, did you have...
Yeah, we're happy to meet you if that's easier and have a conversation rather than wait for a next meeting if that's helpful. We're happy to meet any councillors on this or anything else. So we're happy just to have a conversation if that's easier.
Yeah, I think it's quite a detailed topic. So things have been raised there that I didn't know.
If you have a brief question, please ask it.
Yeah, okay. So the question is, so it was commissioned in an emergency situation to give vaccinations, which is obviously a good use for a bus and we needed it at that point. But I'd really be interested in where's the evidence that it's of any use for health inclusion when you're in a very specific situation, as I said at the beginning. So that's something we could meet and look at and really drill into, because it is something that's been on our work programme for rather a long time. Thank you. Thank you very much, Chair.
Thank you. Thank you. Okay then, let's have a look at the recommendations. Tracy did offer information to the committee on research. Is that something that the committee would like?
Yes.
Yes? Okay, yeah.
That will be, it's going to be published anyway, but we can certainly get it to the committee. The evaluation of research was undertaken as part of the strategic review and we can commit to do that. That's just been tidied up so it looks really nice to read in a glossy format.
Sorry. Okay, thank you very much for that. So I understand people may have some recommendations that they wish to bring. Lucy?
Thank you, Chair. So I'm not sure if this is possible at this point, but I'd like to have some transparent reporting and assurance on GP practice use of funding. So the Inclusion Health doesn't have a known impact there. So to recommend that the ICB establish and report on mandatory assurance requirements for all practices receiving Inclusion Health LES funding, including evidence of designated clinical leads, staff training, delivery of longer appointments, proactive follow-up, coding improvements, and audit of patient outcomes is a recommendation. And that there is a time-bound, costed, measurable delivery plan showing exactly how outreach services will reduce health inequalities. I think that's what you're working to anyway, but including workforce requirements, follow-up pathways, data capture standards, engagement plans and outcome metrics. And that really that we halt any recommissioning or expansion of outreach services until a full independently reviewed evaluation is completed. But I think you covered that at the beginning. That's what I came up with reading the report, thinking we can't go ahead and commission, and that would include patient outcomes, follow-up rates, referral pathways, cost per outcome analysis, and demonstrable evidence of health improvement in those target groups.
I'm not sure that that level of detail on so many subjects is particularly appropriate for HOSC. I'm just going to get some clarification from Becky Tye, please.
So it's for the committee to determine what recommendations you pass, the information that you want to receive. The advice that I would give you is, if it is information that you're requesting, then actually that would potentially be a briefing note for you to reflect on and review. You've got to think about what is it that you'd be able to scrutinise within this committee coming together. What would be the role of the Health Scrutiny Committee to look at that information, and what would be your, where would you be pulling that and looking at that for the benefit of obviously residents, and being able to drill down and look to get outcomes potentially. So that's just about obviously the options that you'd have about getting further information for you to all consider. Obviously any recommendation, I think you just need to be really clear what your recommendation is that you'd be asking the committee to vote on. So it would need to be proposed, seconded, and then the committee, you'd need to vote on that.
Stuart Dark, please.
Yeah, thank you, Chair. And whilst I want to support Lucy, at the same time, just picking up on what Becky said, just a clarification for me. If we were to ask for a briefing paper on all of the potential recommendations being asked, would we then be in a position to make recommendations after we'd received that briefing note? Because that, for me, if we were able to do that, would seem a better approach, because I'm being asked to potentially vote on or second on something that is rather complex and probably got a lot of work behind it. So I'd be happier with a briefing note if I were able to then make a decision on recommendations post that.
I'll let Pallavi speak, and then you. Pallavi, please.
Thank you, Chair. I just want to speak to some of what my previous two councillors have said. I think what Lucy's asking for is drilling down on one particular aspect of the outreach service in relation to GP practices in quite extensive detail. And yet from the paper we see that actually engagement with GP practice is quite small. A tiny number have actually accepted or got extra funding for it. So it seems an odd thing to focus this committee's time and attention on. What I would hope we can agree on is that we ask you to look at every single strand of the outreach service with that level of scrutiny and detail within yourselves, assess value for money, assess impact, assess outcomes for each of those strands, and then come up with a solution that best meets our population's requirements and best meets our outcome aspirations, and bring that to us, to this committee, for agreement, would be my suggested approach. Thank you.
Becky, please.
So just to respond to Councillor Dark's point there, The same as we've done previously. If information is brought as a briefing paper, committee members would receive that. Then at the next committee meeting, if members thought it was appropriate, you could then raise that following the information you've had and propose that as a report for the forward work programme. So that would be one way to get that information, digest it, reflect that in the future work programming of the committee. Alternatively, you can suggest that that would be a report. Obviously, it's got to have that scrutiny element, which is just what I would emphasise. Thank you, Chair.
Thank you. Do you think the suggestion that Pallavi made is a possibility? Is that something you could?
Yeah, we aren't at the point of decision yet. So there is more, and I guess the scrutiny would be welcome on the decision that we make, and have we taken on board all the recommendations that we've made. At that point, we should be able to demonstrate that we've enacted on all of the feedback we've had today, and that we are making robust decisions based on the evidence base and everything we've learned from our people and our community. So I'd really welcome the scrutiny at that point. I think it's difficult because we haven't made a decision yet. So there is, and this is about our future services as opposed to the ones that we've commissioned historically.
How long do you think you would need?
We're aiming to conclude the strategic review by October so that we can commission for the 1st of April. Obviously, we do need to allow a sufficient timeline for procurement if we are to procure anything different to what we have in place. So there would be a window probably within sort of September, October time. It depends on the level of feedback and how much change we might need to enact as part of that process. But we are aiming to get new arrangements in place, whether that's the existing services, something completely different, by the 1st of April 2027.
Thank you. Sorry, Lucy, I did see you waving.
Yeah, I just wanted to echo what Pallavi said, really, that so my recommendation, the last one, was essentially what you just said, that the evaluation includes patient outcomes, follow-up rates, referral pathways. That's for everything, not just for GPs. I said GPs at the beginning, but I wasn't meaning just GPs. That was one strand of the evaluation. So it would seem to me that we've got some distance, and you've put a few directions of travel, some information there, the recognition there's not enough, more is being drawn together. If as a HOSC we can look at that, I would like to ask for us to see that in a timely fashion so that we can scrutinise it, as is our role as a HOSC. I believe that's why I'm sat here today, to help to add value and scrutinise from the perspective of a democratically elected representative, and bring the experience we have to that, so that then we can make recommendations and you can take them on board or not, as is possible, but in a timely fashion. As you say, the challenge will be one of timing, I guess, because if you're trying to commission in April, and the evidence isn't there yet, and we're actually in March, and you need to have the thing written by October, it's going to be quite a squeeze, I'd imagine.
Can I just clarify then, Lucy, are you happy to go to the recommendation that Pallavi made, if we can see if we can get this to a HOSC towards the end of the year?
Yes, with the strong qualification that there's time for recommendations to be enacted and built in, to be listened to. I mean, I know we can't instruct anyone to do things, but our role is to actually put forward ideas.
Okay.
So as long as there's time, for those thoughts to be included, and we can work with Alex on that and perhaps have an early sight of it as well, and work with Healthwatch, be guided by them.
That's good. Thank you then. So can I put to the committee the suggestion that Pallavi made, and also that it comes back to HOSC towards the end of the year? I don't know, we'll have to sort the date out exactly because we've got quite a heavy programme, but certainly before the end of the year, yeah. Are the committee in agreement with that? Anybody opposed? Okay, thanks very much. Thanks for that. Okay, so the actions that were required were to note the early findings of the strategic review and the national policy context, which we've done, to consider the proposed next steps, including phase 2 engagement data, quality improvement and options for future models, and to identify where HOSC seeks further detail, assurance or involvement. I'm just briefly going to go through the things that the councillors said. Let me know if I miss anything out. So Lucy Galvin spoke about costed delivery plan, how will outreach prevent health inequalities, concerns about the absence of audit and external audit, and concern about GP's ability to deliver. Pallavi wanted to know that you would consider older models, not just new innovations. Is it cheaper to arrange transport to take people to centres of excellence or expertise? Leslie wanted to know who are the community voice, and please would you include local councillors as they're a source of great information. She was also keen to know when the actions would be seen. Stuart spoke about available data, challenges, pockets of rural deprivation and trusted partners, and the importance of dealing with more than just people you usually deal with, the trusted partners, but maybe getting newer trusted partners. Victoria spoke of travellers and asked if they were included and about GP practice engagement. Justin echoed the thoughts about councillor engagement and signposting and wondered if there were models in other parts of the country that you could use as an example to base your practice on. Paul wondered whether or not you were using artificial intelligence. And then Lucy came back with numerous questions about the WOW bus, spoke about her concern about the aspirational language of your report, and asked if there was going to be a proper evaluation of the bus and a need for greater detail. I think that's about it. Is everybody happy with that? Okay, lovely. Thank you. Okay, at this point, I'd like to thank you very much for coming today. I'd also like to thank Chris Williamson, who's in the building. His help to HOSC has been invaluable. He's a great person, and thank you for the work that you've done, Chris. Thank you. Sorry. Okay, we're going to move on now to the thing that would have been at the start of the meeting. So here we go. This is the Norfolk and Waveney Integrated Care System digital update. At the end of this, we will have a 15-minute break before we move on to the last. So, can I welcome representatives from the Norfolk and Waveney Integrated Care Board and from Norfolk County Council. So we have here Anne Heath, thank you, and Ed Prosser-Snelling, thank you. Thank you. Over to you.
Thank you. The paper provides an overview of the significant digital progress made across Norfolk and Waveney since your last update in early 2024. In that time, we've moved from planning into delivery, with measurable benefits now being seen across the system. Our shared care record is now used by over 4,000 staff each month, giving clinicians and social care professionals faster, safer access to information. The Acute Hospitals Group continues to progress its electronic patient record programme, ensuring we introduce this safely and sustainably. Primary care has strengthened digital access, which is delivering significant impact for residents. Finally, as we...
No? Okay, members. Stuart, please.
Thank you, Chair. Welcome the paper and also the progress. Just a quick bit of reassurance for me about future-proofing in terms of digital, because it is so important. Obviously, we have change within the ICB and the Norfolk-Suffolk footprint, but in the wider context, we're all aware it's all connected and in the teams that are looking at all of those various models to make sure that actually the disruption, whatever occurs, is kept to a minimum. Thank you.
5 year or so process to consolidate all those applications and systems. But there will be undoubtedly opportunities to join up more effectively the data, in particular. Councillor Neil mentioned earlier the predictive analytics in terms of the implementation.
No? Victoria?
One thing. So it's a single access to multiple systems. People don't enter data into the shared care record. It is read-only. Maybe quite hard because digital, delivering health, it's about getting people into the services and seeing the right clinician. But I could certainly consult with my colleagues in BI about anything like that.
I think it says it's reducing medication errors somewhere.
Oh yes,
that sort
no,
of thing,
that's definitely
which
one.
you've quantified, and it'd be quite interesting to know a bit more.
Adopting it, hoped to achieve, and when they measured it, it was proved to be so. And this is because there can be a delay between people being discharged from hospital with a new set of medications and that information reaching primary care or community services when the patient's discharged. So yes, those organisations measured that as a benefit. In our RPA programme, we're also processing repeat prescriptions faster using robotics, using the rules set by meds management as well. So patients are getting a quicker experience there.
Justin, please.
Hi, thank you so much. Thank you, Chair. So my question is around digital inclusion and people that don't use a lot of digital systems. Sorry, I've stolen your question, haven't I? I'm going to channel one of my fellow councillors who's not here today, who likes a nice scenario. I have very elderly relatives, and I helped them to access the app recently. It's a process, unfortunately for older people. One of my relatives has Parkinson's and found it really difficult. It's how are we capturing, how are we supporting people that don't have easy access to digital systems as well? How are we identifying people that are excluded from the digital transformation? Because I, as a clinician, think it's phenomenal. It's really benefiting me. It's benefiting the patients that I support. But I do know there are a lot of people out there that do not have the digital access that we all perhaps have become accustomed to and are seeing rapid changes for. So thank you.
Okay. Do you want to talk about the...
Yeah, happy to. So Norfolk County Council leads the digital inclusion activity for the county. So although it's led by the County Council, it is integrated with NHS and district and voluntary colleagues. And we have some digital skills people to upskill the people who care for them, who support them. We've also gifted, I think, over 6,000 devices now. Because if you think about digital inclusion, there are a number of factors. There are the impacts we see are phenomenal, and the data is really strong. And if there's anything further you'd like to see, I'd be more than happy to provide more information.
Thank you. Pallavi, please.
Thank you, Chair. I have a few questions. I'll try and keep them brief. I noticed that the launch has been delayed for the EPR. Do you have a date for it? And what was the reason for the delay? Secondly, obviously we're getting 2 new hospitals in Norfolk at some point. How is that going to affect any of this? Is that a problem, or is it just, easy enough to circumvent? I assume lots of thought is being given to backup systems. GP practices have a long history of using digital records. We adopted them far earlier than hospitals. And periodically, with the best will in the world, systems go down. And there's complete paralysis. Nothing works. You can't even draw blood because you have to generate, everything's done on the computer. So I just wonder, how that would, what can be done to reduce the possibility of that happening and what backup systems there will be. And my final question is about care homes. Where do they fit into all of this? I know that care homes would benefit greatly from being able to access their residents' basic information, like just a list of what's on their repeat prescription, for example, to be able to have that direct visibility. Is that on the cards? Is that going to happen? Thank you.
Yeah.
I'm Ed Prosser-Snelling. I'm a consultant obstetrician and gynaecologist, and I'm the Group Digital Director for the acute for Norfolk and Waveney for nearly 25 years now. When the Norfolk and Norwich was built, it was supposed to be a paperless hospital. That has seen a number of significant successes. We've secured funding, which historically we haven't managed to do for 25 years. We have a business case which supports that, a significant number of benefits, which I'd be happy to go into further detail if that's of support, which includes a number of clinical benefits from the EPR, specifically in reduction in sepsis, reduction in failure to recognise deterioration in hospital, and reduction of in-hospital cardiac arrests. We have a team in place who are working in this building, who are moving us forward, but we have encountered difficulties which have resulted in delays, which you'll see in many EPR programs around the country. There are some things around the digital immaturity of Norfolk and Waveney in general, and that has been holding us back. There have been some elements around the complexity of adapting a supplier in who we have great confidence, but who is new to the English NHS, and that adaptation has taken some time, indeed longer than we thought. We were delayed by the general election rules, and that built in a 4-month delay into our programme, which we've been trying to come back against, but that's been challenging as well. But I think probably the most pertinent thing is the fact that we absolutely feel we must be confident that this is a safe go live, that we maintain patient safety, we maintain our ability to report on health back to both regional and national systems, and also that we lose as little clinical elective activity through the transition as possible, because we know we've seen from a number of electronic patient record go lives that clinical care can be compromised, and we've seen a very hard line coming from the central NHS about tolerance from that, and so we've adjusted our plans around that. So the 4-month delay baked in from the beginning. The supply complexity, digital immaturity has led us to take a very measured approach. The predicted go-live now is in May 2027. There are only certain windows which you can go live with an acute EPR. You have to avoid winter pressures. So effectively, you've got a spring and an autumn kind of a launch window, if you like. We obviously felt that it wasn't going to be safe for spring. We don't feel it was going to be safe for this autumn, which moves us into spring of next year. So that's the programme. A lot of progress has been made, and the importance of moving, which I think was sort of implicit in your question, because our ability to provide primary care with data is hampered by the fact that the majority of clinicians are writing things down on paper in hospital as we speak, and we have to change that.
Take away their pens.
Anne,
So I'll answer the questions about primary care and care homes. So in primary care, your question was about resilience. So as you know, GP practices use hosted systems, and they themselves very, very, very rarely go down. If there's an issue with access, that's usually because of the network locally or an issue with the smart card software. So over the past 2 years, we have replaced all the networks in general practice with a resilient software-defined wireless access network that has got 2 lines into the practice, an embedded Wi-Fi, and has been transformational for the practices. It doesn't go down as much as the old, well, it doesn't go down. And so there's, if somebody, obviously, you know, took a JCB through all the lines outside, then of course things would go down, but it's much more resilient than the old HSCN networks. With regard to care homes, so there has been a programme to implement the digital social care record, and that programme was stood down nationally, but they are hoping to progress in the next year with a programme called the Social Care Interoperability Platform that will bring the information from the digital social care records into a joint platform that can then interoperate with the shared care record. So you'll have that joined up view in care homes and anywhere else that the information is needed.
Thank you. Councillor Galvin. Oh, sorry. I beg your pardon. I saw something. Councillor Bembridge, sorry.
Thank you, Chairman. I've just looked at my record on my app, which I must have got about a year or so ago, and I do find it quite useful. I don't agree with everything that's on there from my patient record, but I'm going to deal with that. But I've had a few appointments because I've got an eye problem, and one of the last appointments I had was in February, and I can't find that on there, but a January appointment is now on. But I have an appointment next week and that's not on, so there's a delay. Now, that's all right for me because I can cope with it, and I actually did receive a letter, which is another issue, isn't it, about patient letters not arriving. But what I'm more concerned about is, following on from Justin's comments about people that aren't digital, and we may have given out 6,000, was it, old iPads or whatever it is. But what about the people that don't have internet because they do not understand it, do not want to know because they're elderly? They're the people that need to be have their records integrated so that if they do have to go to hospital, etc., then it's known about. So to me, I've realised there's a delay in getting that information. But of those few appointments I've had recently at the hospital, not once have I been asked if I've got the NHS app. So that would be a good question to ask right from the outset and to explain it. And I know that it is possible to put on the app that you want to look after somebody else, and I'm not at the moment, but my neighbour doesn't want me to help her. But she's never going to get a mobile phone, a laptop, or internet. So what do we do there?
Shall I? Okay. So I suppose one of the advantages of having the digital access methods is that those of us that want to use them and can use them do, which frees up reception time for people that don't. So it's not a case of everybody has to go digital. The non-digital access methods are still there, and that was one of the drivers behind the investment in cloud telephony to make the access by telephone better. So now practices can, put you in a queue and call back, and people are getting a faster response time. We're also, though, you mentioned some issues with age. So there's lots of things that go on where GP practice PPGs will run sessions for their practice population, or we also provide practices with tablet devices so that they can help patients who go into the practice to either to use digital access or to explain something to them, or actually for translation as well, where first language is not English, so they're using digital still to help people access it. But the aim of the whole digital programme isn't to move everyone to digital access methods, it's to switch people who want to those channels.
If I might just say that there's another element of people that you have mobile phones and obviously connect in some way with Facebook or whatever other social media, but they're not actually using it for other things that we might consider that they are. They're not using it for learning or anything like that. So, there's but I was really concerned about the delay between the access. So if I'd been rushed off to hospital yesterday, or went to my GP, that information about my appointment next week wouldn't have been on there. Should I need, it's not, I'm not taking drugs or anything, but medication, but there are things that it might concern. Yeah. So it is about the delay, really, I'm asking.
So without prying into your healthcare circumstances, information will go into the NHS app like, from the GP practice almost immediately. If it was a hospital appointment, there may be some delay there, and that may depend on what legacy system they're with. So the work that Dr. Prosser-Snelling was talking about with implementing the new EPR will absolutely improve the timeliness of information going to the NHS app and the richness of the information that goes to the NHS app too. So the more we move forward with the digital programme, the better the information on the that's available in the app will be.
Sorry, it's not just the app I'm concerned about, it's the communication between GP, hospitals, about if there's a delay. If I've had a delay on the app, is there a delay getting that information through from one department to another?
I mean, you know, there may or may not be. I think you know we would have to look at the specific circumstance to understand. So we have the shared care record, for example, and that does not yet interface with the NHS app, although will in the future. But the information for appointments will go to the shared care record, and clinicians will be looking at that more than your NHS app. So possibly that's a place that a clinician would find it.
Thank you. Ed, please. Do you have a... You know, oh, sorry. Sorry. I beg your pardon. Sorry, that Ed. Sorry, different Ed.
I was just going to provide some further clarity to the Councillor. I think that your illustration underpins the absolute need to move to an integrated digital system. So what's happening there is the app is actually receiving information from two different places. So it's receiving some information from the GPs and some information from the acute hospital. At the moment, because we have outdated legacy information which we're just keeping going at the acute hospital, which is planned to be replaced by the EPR, there is potentially a delay, and we are reliant on patients to hold that information to a certain extent. And once we move into the future state, we will alleviate that burden on patients.
Thank you.
Okay, Peter now.
There we go. Yeah, thank you, Madam Chairman. It's a bit of a follow-up to what Leslie mentioned. Has there been any consideration to the extreme rural areas and some of the north coast areas where they haven't got or very poor internet? That is, the last figures I had, 30% of Norfolk didn't have internet access to internet or very poor internet. So if there is people out there who do want to, obviously got to go to digital, then that's something I think you should be looking at, working with the authorities or the telecom, whoever they are nowadays, to bring that forward.
Wasn't playing. So super fast broadband, which is at 30 megabits per second, which is generally usable for most things these days. That's currently at 98% across the county. The figure you're referring to as a 30% not available might be gigabit fibre, which is up to 1 megabit. Sorry, 1 meg. That is rolling out fast through the Project Gigabit, where we've got £150 million of inward investment from central government. And we're just waiting the specific timings for when that rolls out to the north and west, which has been an additional element. But as I say, at the super fast level, it is available across the whole county at the moment. The other thing I would add is 98% is come a long way from where we started. When we started Better Broadband for Norfolk at 42%. However, it's clearly not good enough. We need 100% coverage. One of the things that we've been testing recently with the council is low Earth orbit satellites. I don't know if you've seen, but they've recently dropped down to a monthly cost very similar to regular broadband. I tested that recently and was getting 150 meg. So finally, we're at a point where anybody who wants to have internet connectivity, even if they're in a very remote location within Norfolk, can get that access. So I think fixed broadband is good generally and getting much better through the inward investments coming in. Mobile is our big challenge. Better Broadband for Norfolk has invested significantly local money and national government money to make those improvements. When it comes to mobile connectivity, All we can do is lobby Ofcom and the mobile network operators and give them the data about where the gaps are, and we all know there are very significant gaps around the county. So that's one we're pushing very hard on. But broadband should be fine, and I'm very happy to follow up with the council on any specific locations and provide any more maps. And just one more thing, if I may. We provide all our district colleagues with equipment which we put onto the bin lorries. And so that means every fortnight, when they go to every home around the county, they map that mobile coverage. We know exactly where the coverage is and where it isn't. Okay, thank you.
Thank you. I do have two more people wishing to speak, Paul and Victoria, but before then, can I just ask a quick question? And I know I've probably asked Anne this before, and this make me sound a little paranoid, but with the problems that maybe this country is having with the United States of America, in terms of backup of systems, are we entirely reliant on stuff that comes from the United States, or is there any more homegrown or European sort of backup that could be used? As I say, forgive me if I sound paranoid, but the world is changing so fast right now.
Yes, I mean, I suppose that's quite a hard question to answer, isn't it, in terms of what might happen. But what we do know for assurance is that where a company like Microsoft or Meditech may be based in or originate from the United States, we're very much using a UK or Ireland-based connection or branch of that company. There are laws around where the data is stored, for example, and all data is stored within the law and absolutely not in the United States. So we're not regularly making any connections to there, but would acknowledge that companies like Microsoft and Meditech and Amazon were originated in the US, but do have significant European and UK presence.
Thank you for the reassurance. Paul, please.
Just a question from our officer. You used figures of 42%, 98%. Is that area coverage or number of people? Because I get this with mobile phone companies saying that we cover 99% of the country, but that doesn't actually cover 99% of the area. I live in the city of Norwich, and this inconvenient railway embankment near me means I can't get a mobile signal on the ground floor, and I'm in a city. So what can you clarify those figures?
The figures I was quoting are for individual properties connected to broadband, so fixed connections at the superfast and the gigabit speeds. They're all available. They're all independently provided, so you can check those. They're not just Norfolk County Council figures. The mobile figures I haven't quoted, and the reason I haven't quoted is because I don't agree with them remotely. They are aspirational, should we say. They're computer-generated predictions, but when we run the analysis, we find that the reality is very different on the ground, as we know. Those fortnightly runs across the whole county show that it's more like mid-80s% coverage as opposed to the 99 point something you'll read based upon the information that the mobile network operators provide to Ofcom. So yeah, I'm very confident in the fixed broadband figures, not so confident in mobile.
Thank you. Victoria, please.
The time may have passed, but I'm somewhat sceptical about the coverage in North Norfolk of fixed internet. It's appalling. I've got villages that don't have it at all, so perhaps you could prioritise where I am. That would be great. Thank you.
Pallavi, please.
Only to say we have very poor coverage where I live, just because I'm so rural, and I've got satellite broadband, works fantastically. It is an option. I think there's no excuse anymore. The cost isn't any more than what you would pay for regular fibre broadband. So, yeah, I think that problem is solved. It's more about whether people then take an interest and take it up.
Okay, any more? No? Okay. Thank you. Before we look at recommendations, the action required today was to note the progress made in delivering the Norfolk and Waveney digital strategy, comment on the areas of digital development where further scrutiny or assurance may be required, and the committee may wish to consider whether or not to make comments or recommendations as a result of today's discussion. Does anybody have any recommendations, please? Gosh. Oh yes, Victoria, please. Thank
Well, it may be too early, but I would be, it does say that this offers opportunities to improve productivity, quality and population health, and I just would like to see that data. It may be too early to have it, but you mentioned you had some certainly acute-based data based on the digital transformation that's happened so far. I don't know what you feel about revealing that of the transformation, whether it's too early because it hasn't been fully implemented.
Okay. Before we consider that as a recommendation, do you have a timeline, or do you have information that could be provided maybe in a briefing note? Or?
I could certainly commit to talking to my colleagues in data and getting some information for you. I'm sure we could, yeah.
Okay. Okay. Becky's just saying if the committee agrees to that proposal, then she can liaise and get the information and get it to everybody. Is that something that people would be happy? Yes? Anybody in disagreement? Okay then, thank you. We'll have that as a recommendation. Right, I'm just going to quickly go through what I think people said. Stuart wanted reassurance about future-proofing, don't we all? Victoria wanted to know how does EPR link with other systems, and wanted data on improved access, outcome data and benefits to patients' health. Justin, digital inclusion and how are we identifying and supporting those people who need help? Pallavi wanted to know about the date for EPR and why it was delayed, and will that affect the 2 new hospitals, and spoke about backup systems and asked where care homes fitted in. Leslie was very exacted about the delay in records being updated. Peter mentioned extreme coastal areas where he said that 30% of people in Norfolk have poor digital access. Paul questioned the figures that had been given and asked for clarification, and is having problems with the railways where he lives. And Victoria spoke about coverage in North Norfolk, and I mentioned my paranoia about the United States of America. Have I covered everything with that one? Okay then, thank you very much. Can I thank you so much for coming in today? That's great. Becky will be liaising with you, so thank you very much. We seem to be ahead of schedule, so were you going to say something to me? Yeah. What I'm going to suggest now to the members of the committee, because we had thought this would be longer, we don't have people coming for the last thing that we're dealing with today until 12 o'clock. So I'm going to suggest that the committee now pauses until 12 o'clock, where we will resume with a report from the Mental Health Trust. Is that okay with everybody? Right, thanks ever so much. Thank you. update report. Before we, and as we have a local member and members of the public here who have registered to speak, I'd like to set out the order in which we'll take this item. I'm first going to invite representatives from the Norfolk and Suffolk NHS Foundation Trust to introduce the report and give a presentation, and that will last for 10 minutes. We will then hear from our speakers, who will each have up to 5 minutes to provide any additional insight for the committee. Following this, representatives from the Trust will have up to 5 minutes to respond, should they wish, to any points raised by the speakers. We will then move into the committee's discussion. So can I welcome representatives from the Norfolk and Suffolk NHS Foundation Trust and ask them to briefly introduce themselves, the report, and share their presentation. Now, I have a list of people here, and I hope you're all here, and if I'm missing anybody out or you've been substituted, let me know. So I have Caroline Donovan, Kath Byford, Roy Marsh, Gary O'Hare, Tom Davis, Anthony Deary, Rebecca Driver, Richard Watson, and Daniel Dalton. Okay, did I miss anyone? Nope. Okay, brilliant. Thank you very much. We've received 3 requests to patient. Are we ready for the presentation now? Yeah. Brilliant. Okay, fire away.
Thank you very much, Chair. I think just before I come in, Richard Watson wants to say a few words, if that's okay, from an ICB perspective. Thank you.
Thanks, Caroline. Thanks, Chair. So just to set the context first before we go into NSFT. So as you know, the Integrated Care Board is coming into its new incarnation from the 1st of April, covering both Norfolk and Suffolk. And we're embarking on a piece of work to develop a mental health strategic plan, which will cover both the counties, but we'll go into some more detail around what is it we're actually aiming to achieve from an NHS perspective with and for our local population. And we're very keen to engage with HOSC later in the year around that. But just turning to NSFT, I've been working with the Trust for 12 years now, and it's been a journey, I would say, and particularly for the last 2 years, there's absolutely been good progress, particularly in terms of quality, performance, and more broadly, the active now engagement of the Trust at all levels into the system and into what we need to achieve with and for our local population. However, there is clearly still a huge amount to do, and that's obviously going to be part of the conversation that we get into in a second. But I just wanted to put on record that because I think it's tantamount to the work that Caroline's done and the team in terms of the changes that they're making, the positive changes they're making, and the engage of what we need to achieve more broadly for our population.
Thank you very much. And I think, Becky, you're going to kindly, if I just nod to you, that would be absolutely brilliant because we haven't got a clicker. So really very mindful of 10 minutes and I will hold myself to account over that. So if we could just start with the first slide. Really helpful to just hear Richard's perspective. And I think our really strong narrative is we're on a strong improvement trajectory. We absolutely know there's a lot more to do. This organisation, and I'd say the system, has been fairly dysfunctional in servicing the population in terms of mental health needs for well over a decade. So managing to turn that around and to be able to offer good, consistent services without variation is certainly our ambition, but one that we have a long way to go. So right at the really heart of our priority was appointing a strong leadership team. We now have a substantive and experienced leadership team, both from a non-executive and an executive perspective. From an executive perspective, we have 5 execs that have worked in CQC-rated outstanding mental health trusts. So actually bringing that experience and expertise is right at the heart of our improvement journey. We've also restructured the organisation into localities. Our very, very strong ambition is to provide local services that are sensitive to the local population and, importantly, that our leaders are very, very visible in localities and in neighbourhoods so they understand and are leading the quality improvement of those services. We've also really strongly strengthened clinical leadership. So each of our 5 localities have a director of nursing, a medical director and a director of ops. They also have a director of psychological therapies and allied health professionals. So we've invested in our new structure in 32 new community matrons. So right at the heart of our leadership is patient care and real strong on clinical leadership. We've developed a new strategy that is guiding everything we do. We're going into the third year of this strategy. And very clear, we have improving health, improving care, improving culture and improving value. We have 12 large-scale change programmes that are at the heart of everything that we're doing, with 3 strategic priorities for each of our overall strategic areas. Next slide, please. Right at the heart of our transformation is our clinical pathways. So we knew, if we go back a couple of years, there was significant variation in our clinical pathways. If I just say, for example, in memory assessment services, there were 5 different models that had been commissioned, lots of variation, and we've now got 5 clear priorities. Next slide, please. This gives you just a little bit of the meat on the bone around what our priorities are. From a community mental health perspective, there's been significant variation, lots of fragmentation and lack of consistency and collaboration across teams. It's right at the heart of our work that we are doing to strengthen our community mental health model. Big part of that is working with our partners, particularly our primary care partners, our social care partners, our voluntary sector partners, but also our acute sector partners and police. Crisis, I think there'll be many stories of people not being responded to in a crisis in an effective and consistent way. Again, we're really investing in our crisis pathways. We have a new immediate response service, an IRS service that we are right at the heart of developing, and the first part of that will be live from the summer. Significant amount of work on our inpatient wards. Across all of our inpatient wards, we have a programme called Culture of Care, where we really focusing on person-centred care. Again, a lot of work to do. Children, young families, children, young people, one of the massive issues for across the country as well as here in Norfolk and Suffolk is children, young people getting access to service and support. We've done a massive amount of work, both in our generic children, young people's pathway and in our neurodevelopmental delay pathway. And by the summer, we won't have anybody waiting more than 12 months for treatment. It's still a very long time, but compared to where it was, which was over 5 years, it's significant improvement. And again, we've got a lot of work that we were doing around our older adult pathway, particularly in partnership with wider partners. Next slide, please. At the heart of our community transformation is really wanting to work with our neighbourhood partners and really focus on left shift and supporting people so they don't get into a crisis. We've put in a bid for a number of neighbourhood health centres, 7 neighbourhood health centres. At the heart of that will be partnerships with voluntary sector and other partners. And we're excited. The work that we've done to identify where those neighbourhood health centres should be is based on where our populations are living and where the most demand is coming from. We wait to hear around the bid that we put in, which is for 15 million. Next slide, please. This just gives us a little bit of context. You can see how reduced waiting times for people to get into services across our pathways. Next slide, please. Of course, CQC is an important regulator to assess are we actually improving services. We've had 5 inspections in the last year, and we're pleased with the outcome of those inspections. They all have shown so far a really strong pattern of improvement. And for the first time in our most recent inspection of our forensic services, we started to see some outstanding rated characteristics, which is really brilliant. And that was around evidence-based care and the involvement of service users, carers and families. Still a lot of work to do and a lot of humility around that. Next slide, please. The heart of our transformation is really listening to the voice and responding to the voice of service users and carers. We've by no means got this right. We've still got a massive amount of work to do. But we have now established a trust-wide service user and carer council, and Roy, who's one of the co-chairs, is here with us today, as well as 5 locality councils who are very, very embryonic. Next slide, please. This shows it's only one lens, and it's an important lens, but we need to understand the experiences much more than just the friends and family test. But you can see when people are rating what the experience was like, would they recommend this service to friends and family, that they are improving the overall, both the response rates, which has increased significantly, and also the number of people have gone from 63% to 83%, rating the experience as good or very good. That doesn't mean that there aren't plenty of stories where we're not getting it right. Next slide, please. Our culture is right at the heart of the changes that we need to make, and particularly as this has been an organisation for so long that has been challenged. We have some brilliant staff in our organisation, but they haven't always worked in an organisation that support and developed them and enabled them to thrive and deliver really high quality patient care. A big part of our focus this year has been to increase the response rate from our staff survey, and you can see that we increased that by over 20%, so that it's much more representative of how people are feeling. The results of the staff survey have literally just landed, and what it shows is some real pockets of variation. So some teams and services are performing in the top 20% nationally, and others are not. And we've got variation between services and variation between localities. Overall, we've got a way to go, and this is at the heart of our priorities. Next slide, please. A big way that we're approaching our cultural change is through listening and acting from feedback that teams themselves give, and that they are at the heart of our LIA, or Listening into Action programme. We've had over 350 people that have been involved in our LIA programme. We've just launched our 3rd wave, and you can see there we've had over 50 teams that are focused on a whole range of improvements, and they've also delivered over 300 improvements called quick wins.
You've
really
1 minute left.
Thank you. Really trying to get to the heart of acting on feedback, and staff themselves, teams themselves, leading the change. Next slide. I won't go into the detail of that, but that just gives colleagues the detail of those, the latest pioneering teams. Next slide, please. Big part of our cultural change is focusing on race. We know we have significant issues, the same as society, around race equity. And again, I won't talk about the detail of that. It's in the report, but we're determined to move the dial on improving the experience from colleagues from our global majority. Next slide, please. And what this shows importantly is some of the impacts of our cultural change, so we can start to see massive reduction in both vacancy rates and turnover. Next slide, please. Our final slide, I think, which is the ongoing challenge we have, which is akin to everywhere in the country, but particularly challenging for this organisation, because you can see on the right-hand side the efficiency programme that over the last 5 years has increased in terms of what's been expected to be delivered through national policy, but also a real focus on transformation. So the blue part of the graph is showing where we're managing to deliver efficiency recurringly, so that we're not increasing an underlying deficit, and that's only delivered through real transformation at the heart of our plan. I think that's our last slide. And I'm just going to ask Roy, if I may, to just say a few words from his perspective.
I'm really sorry, but you're limited at this stage to the 10 minutes. Will the committee be happy just to give a couple of minutes extra? Yeah, okay, lovely. Fire away.
Thank you.
Over to you, Roy.
Yes, thanks, Chair, and everyone here today. Literally, my background is that I've had 10 years under services, felt many frustrations over the years, attended many groups and had much support, and eventually I've now been able to find myself as a co-chair of the Service User Carer Council for the Trust, and I'd just like to pass on kind of my experiences in that how valued it feels to be a service user who can now actually sit near the top table and have my voice listened to. You know, so many times we hear in mental health services around, yes, we hear you, we hear you, we hear you, but I actually feel that we're actually listened to now. And I'd like to just say I think that's incredible to be given that opportunity as a service user. I'm still under services, but for me, I think a key word is hope. And I think, you know, the rollout of the Trust-wide Council and now across the 5 localities is going to be a fantastic tool in getting service users and carers' voices back in to the heart of the service development and improvements and help influence change for the good. So, very good. Thank you.
Thanks very much. I will be equally generous if the guest speakers wish to carry on for just a couple more minutes. Okay. So, the people I have here who wish to speak now are Natalie McClellan from the Campaign to Save Mental Health Services, and then Emma Corlett, who is County Councillor, and Simon Case from Unison. So, Natalie, you've got 5 minutes. We'll warn you when you're near to the end of your time. Okay, thank you.
Hi, I'm Natalie, bereaved parent of student paramedic Rebecca McClellan, who died under the care of the Trust in 2023. Following her death, I found that the failings in my daughter's care were not in isolation, but unfortunately as part of a history of a trust that had been allowed to fail for over a decade. I joined the campaign to save mental health services in Norfolk and Suffolk, not from a place of anger, not because I can bring her back, but to drive an improvement that will stop other families losing their loved ones and other service users suffering the way she did. I stand here today as a voice of the campaign, its committee and its members as we reach the halfway mark of the new leadership team's 5-year transformation plan. We met the leadership team in May 24 and spoke of the collective grief in the area. We were assured that in that meeting we were now led by the transformation experts who we could trust. So here is what we see as people who are interacting with the Executive Board and with our care coordinators, as members of the Service User Carer Council, as someone going through the inquest process, and as members of the mortality group, and as carers of people in mental distress. The Improving Care workstream, fundamental in core services, began very promisingly but is already plateauing. The foundations of safe practice, such as care plans and risk assessments, are still not being recorded or used effectively. We asked the Trust Board to speak to the service users and carers during care plan audits, as we have evidence that our patients are not actually getting the care that is written down. Support workers or care coordinators are written as assigned despite not actually being assigned at all, creating a false picture of robust support. Service users are still sent on a wild goose chase in search for clarity as record keeping remains poor in places. This causes issues with handover between staff, further hindering communication that has continuously been a point of concern within the Trust. As of January, storm training for effectively assessing risk assessment was woefully behind schedule, with only 20% of staff working with adults and 43% of people working with children and young adults receiving it in the first 14 months. Behind in trajectory due to not enough staff on the ground to take them out safely for training. Community teams are overstretched, and we have examples where the Trust are not being proactive in taking preventative measures or reacting to risk. Care coordinators within community teams are not being replaced. People are still on managed waiting lists, and we ask, are these recorded separately from the treatment waiting lists? Inappropriate referrals are being sent to external organisations where care is well within the CMHT remits. Whilst crisis intervention times are improving and the out-of-trust beds have reduced, people are still being denied help. Following up care with community teams is still poor, and patients and carers are being left to navigate crisis by themselves, and people are waiting over an hour on 111 option 2 on a regular basis. We have evidence that Mental Health Act assessments are being delayed until in-area beds are free. Does this suggest that the Trust is protecting targets over protecting their patients? Since the CQC inspection, many things have stopped or slowed. I sit in the mortality group, and since uprating, we are no longer looking at the deaths and safety incidents in the way that we were. We are no longer receiving the mortality reports as part of this process. We have had overall patchy attendance from leadership. The mortality data was described by the Trust as a gift at the Suffolk Hosp solely for the FO-produced health equity plan. While that holds so much weight and importance, this should be a separate piece of work entirely, as it discounts the unique and long-standing failures of the deaths that happened during the catalogue of disasters. Committee, you were assured that last year's staff survey results were due to being, I quote, smack in the middle of our restructure, with undoubtedly causing anxiety, concerns and fears that can't help but have an impact. This year's staff survey has now been published. The results have a worrying picture that directly contradicts the Trust focus points for improvement. On speaking up, only half of staff felt safe enough to raise concerns. Only 43.9% are confident that concerns about unsafe clinical practice would be addressed. Only 57% of staff believe that the Trust acts to prevent incidents from reoccurring, the worst in the benchmarking group. Rather than a culture of safety, it is one of learned futility. On leadership, concerningly, NSFT falls below average on every compassionate leadership question asked. This has been the same below-average performance since 2021, when leadership was openly troubled. And on care, still staff do not trust the organisation to care for their own loved ones. We know the campaign has been seen as a persistent entity of challenge over the last decade. However, the points we bring to you today are from the Trust's own data and from new members of our group and members with present living experience. We urge you to give weight to our points in the same way NSFT's ambitions are trusted during the committee's own calling for a public inquiry in 2024. As a bereaved mother who stands here in front of you, who will be sat in her daughter's delayed inquest next week due to the Trust's repeated delays in investigating her death for 16 months, I ask you to properly scrutinise the information you are given, to question the narrative and to hold this Trust to account to ensure that the most vulnerable people in Norfolk and Suffolk receive the safe care they very much deserve. Thank you.
Thank you, Natalie. Thanks very much. Can I invite Emma Corlett to speak now, please?
You can. Thank you very much, Chair. I wanted to speak about the reality of mental health access in Town Close, the area that I'm councillor for. I'm sure Town Close isn't an outlier, and this is probably typical of what is in your divisions. I'm going to focus just on things that have occurred in the last 6 months. The reason I'm going to kind of describe these things is because when I looked at this report and the limited data, what has been put in front of you doesn't tell the story, the so what are patient outcomes, what kind of quality of life do people have, and are people living good and safe lives if they manage to a service. So I'd like the committee to sort of question how you can effectively fulfil your scrutiny role if the kind of things that I'm going to describe, when these papers come to you, you wouldn't actually be able to know whether that was happening in your community or not, and that's kind of the aspect that worries me. So I kind of group it into several different themes. The first is those that still can't get in to the service. And I'm talking about people with severe and chronic psychotic illnesses who are vulnerable to exploitation, sometimes are being actively exploited, having their properties taken over, high levels of self-neglect, shocking physical health inequality, struggling to maintain a tenancy, quietly distressed and unwell, and literally fading away in some cases to death. Because there's no necessarily overt behavioural disturbance, these might not be people that are coming into conflict with their neighbours. They're just kind of there, deteriorating. And I can think of a number of people that meet that criteria that I see on a regular basis in the immediate area where we run our community cafe from. Obviously, it's right that communities support each other, but there is a limit with what we should expect people to do. And then there's those who are in a service stretched, as we've already heard, care coordinators not being replaced or people not being seen if someone's unwell, the pressures on caseloads and maybe those early warning signs of relapse not being picked up because of a pressure to see people at a base or make a telephone call rather than actually see people in the environment that they're actually living in, so you can see whether they've got any food in the house and whether they've opened their post over the previous 6 months. And then, so not picking up on those early warning signs, so people ending up being admitted in crisis still, sometimes in quite distressing circumstances. So, for example, we had someone that I know concerns have been raised in the previous weeks by the police. Lack of dignity. This person was naked, sat on the wall in our park, very disinhibited, very unwell. Their route into care was via the police. It then took 4 police officers out for quite a long period of time. We had to wait to get a female officer in place, and members of the public were filming that person as they walked past as well. So that was a complete breach of their dignity. And then people that do manage to get admitted, I really remain concerned about unsafe discharges and how quickly people are being discharged. We're seeing people still overtly manic, still floridly psychotic, causing all kinds of problems. I said when I was a member of HOSC years ago, to see that, we really need to know what is the readmission rate. You know, if someone needs to be readmitted 3 days after being discharged, I think it's a reasonable question, were they ever well enough to be discharged in the first place? And the follow-up following admission is still chaotic, judged on what we're seeing. I'm seeing in my community. And you've already mentioned the delays in getting a bed if someone's been assessed under the Mental Health Act even, and a bed's needed. We're seeing really long waits for a bed, and I can't see anything in this report that tells me or would tell you what if any, harm occurs during that intervening period.
You're about a minute.
Thanks, I've got my time on. And the impact on families and carers that are trying to manage that situation. So I think there's still an unanswered question. Yes, you can say you've brought down out-of-area admissions or out-of-trust admissions, but at what cost if people that meet the criteria for being admitted to hospital are being left in the community without that care and support? I also wanted to pick up on the no prevention of future deaths notices issue since November 2024. Now, I've read the news reports of some of those inquests that I've been surprised there's been no prevention of future deaths notice, because there are similar themes of deaths before. The Trust will know full well the coroner cannot issue a prevention of future deaths notice if an organisation puts in front of it another one comes down the line with exactly the same themes. There's not involved, so that's a real gap. So I'll leave it there.
Stop.
Okay,
Thanks
thank
very
you.
much. Thanks, Emma. Okay, then my final speaker is, sorry, let me put my glasses on again. Simon Case, please, from Unison. Thank you.
Thank you, Chair. Thanks, committee, for letting us speak today. I'm here today to raise concerns on behalf of the talking therapy counsellors employed by Norfolk and Waveney Mind. They've been in dispute for 18 months with the employer, and they've got serious concerns through what has come out of those discussions with the employer. NSFT may not be meeting the legal requirements for NHS patients. Made repeated attempts to explicitly clarify with NSFT, but corresponding responses have been needlessly opaque, therefore raising alarm. If Norfolk and Waveney Mind delivering Step 3 high-end therapies NHS handbook clearly states that they should be. NSFT are refusing to hold Norfolk and Waveney Mind to the contractual term to deliver NHS talking therapies aligned to the NHS Talking Therapies Manual. In remuneration banding for counsellors, which is expressly written in the NHS Manual, this is creating a situation where a group of predominantly women workers are being paid trainee rates of pay, despite being fully qualified and accredited. This is undermining NHS fundamental principles of equal pay for equal work. If NSFT took the simple step to choose to enforce a contractual arrangement with Norfolk and Waveney Mind to ensure alignment with the NHS Talking Therapies Manual, this ongoing pay inequality issue would immediately cease for these workers. For the last 18 months, we've been in serious discussions with Mind and NSFT so that we can end this dispute. It has been going on, it is affecting service users, and the last thing the councillors want to do
is start new industrial action, which will again affect patients. Thank you.
Thank you very much. If you want to respond, I'm going to turn to the representatives of the Trust now. You have a 5-minute response. Can I just emphasise that this isn't an opportunity to question the people that have just spoken, but it's an opportunity for you to respond. Thanks very much. I'm going to try and stick to the 5 minutes exactly on this one. Okay, thank you.
I'm not sure, to be quite honest, Chair, how we, because there's so much in there. There's nothing that's been said that is new. I mean, I guess very happy to answer any specific questions, but in 5 minutes I can't answer all of those. What I'd say is understand the themes, and it's at the heart of the work that we're doing.
Okay, thank you for that. Can I ask now, please, the people that spoke, if you wish to see the rest of this committee, could you please take yourself to the public gallery? Have a bit of a pause while that goes on. We've got somebody here who'll shepherd you in that direction. Thank you. Thank you. Thank you. Right. Can I ask members, please, if you have questions? Please raise your hands. Okay. So, Lucy first, then Stuart, then Victoria, Paul. Anyone else? Me? Thank you. Okay, can we start, please, with Lucy?
Thank you. I'd like to start by saying thanks for the visit and thanks for the report. It's really useful. And there's obviously a lot to pick up on and a lot of issues that have just been raised that are important that HOSC do ask questions on. So we've got a report, we've got a set of issues as well. And we're going to have to be quite disciplined about trying to address all that, aren't we? And I'd want to perhaps bring back any questioners in the future and make sure those things are addressed, because there are some really important issues that are raised there, and I particularly like to thank the people that came. I know it's not easy to sort of relive difficult experiences in front of people, and I think it's really valuable for everyone to have those voices in the room. So thank you for having the energy and courage to do that. It's helpful to everyone, I think, especially the service providers, to make sure that happens. So it's everyone that's speaking here on behalf of service users. Thank you. So yeah, having said that, and I think I'll probably speak for everyone there. So yeah, there are a lot of questions in here, and I'll start with one about transparency and learning from deaths. The report says that there's a credible mortality reporting system and that learning from deaths has improved. But we've heard families report stalled investigations and halted mortality group works and deaths being attributed to natural causes without proper inquiries. So it would be good to have the current number of deaths that have not received a full review under PSIRF, the timeline for completing those overdue mortality reviews, and sort of some linked evidence that the themes and learning are being acted on rather than being, deprioritised in favour of the health equity plan, and a linked question really about what we can do about the coroner issue, the issue of, I don't know if I've got the correct terminology there, but that was raised, that things can be kind of, I might need a councillor call it to help with the actual terminology around that, but I'd probably like to recommend that we ask a national question about that. I can come back to that. So yeah, I'm not sure who's the right person to answer. Thanks.
Thank you. Shall I I'll start us off. Thank you very much. So in terms of people will maybe have a memory of the real challenges that the Trust has experienced historically in terms of reporting mortality, and I'm very, very aware that every death is a death that's happened to a family, and I also concur with your thoughts, Councillor, around the difficulty and honesty and transparency of which other colleagues have come and talked about that. So we now report our mortality data transparently in every single one of our public trust boards. We've invested a lot in a new system, and we've had that externally assessed and assured. Now, I'll ask Gary to just say a little bit about that, just in terms of the process, and then I'll ask Anthony, who's our chief nurse, to talk a little bit about the so what, because that's, first of all, it's really important that we're able to understand how many people are dying, how they're dying, and then, along with every other trust in the country, what are we doing as a result of it? In terms of the prevention of notices, obviously...
Which draws the data into the organisation for analysis. But the other point, we actually had it independently reviewed, technically reviewed, both in terms of the quality of the information which is pulled through the system, but also, I suppose, how it helps us analyse that. So that was undertaken by Niche, which is has a high reputation nationally in terms of investigations into various different systems and processes. And they came back with a very, very positive report. That report went through the public board in NSFT, I think, in 2024. And we've also, in NSFT, I think, in 2024. And we've also engaged Niche going forward to look at how we can improve our learning processes as well. So the first part of the process is very much around getting the systems right. Will be around how to improve the learning, and then the final phase, again, if you remember back to 2023-24, is about how do we start and measure the impact. So that's the process. I'll pause there, Caroline, and pass back to Anthony.
Thank you. I'll just ask Anthony, our chief nurse, to come in and say a little bit about the Learning from Deaths group and how we're learning. Thank you.
Thank you, Caroline. Just in terms of the learning from deaths and the systems that we've had to sort of put in place in the Trust, we did a complete review of how all of the learning from our serious incident reports were kind of embedded within the organisation. So we've now got a weekly trust-wide safety group where all of our deaths are reported through that trust-wide safety group. That has membership from all of our locality teams, senior leadership teams. We've put in place quality improvement leads that work between our Safer Care Directorate that manages our learning from deaths to work with the locality teams to follow through on the reports, the learning that's been identified and the actions that need to be taken forward to make sure that those actions are embedded, that they're reviewed routinely, and that there's evidence of progress being made. We've still got a lot to do around this because this is all sort of early stage development work, but we've had to put in place, processes that are rigorous and robust to help us with this. We had a number of overdue serious incident investigations. Apologies, Councillor, I haven't got the number in front of me at the moment, but I do know that by June of this year, there will be no overdue serious investigations to complete. The plan that was reported through our most recent trust-wide safety group was that by June, all of those will have been completed, and that we will then be operating within the expected timeframes for the completion of any more serious investigations that we need to undertake. So the position wasn't great, but the plans that we've put in place now, I believe, have improved it and will take this forward for us.
Thank you. Lucy, you...
It might be something that we come back to, but on the national oversight, so there's a national point around the prevention of future deaths notices, especially when they're issued by the same organisation or on themes, for themes previously identified. That's the issue raised, wasn't it, which you allude to. I wonder if as a committee we could, I know it's beyond the scope of it's a national issue, so just to mark now that where we write to the relevant ministers regarding that gap in national oversight. So write to the relevant, I know we're pushed for time, that's why I'm putting that, just getting it marked in now, write to the relevant minister regarding the gap in national oversight of prevention of future deaths notices, especially where they're issued to the same organisation for themes previously
Can I just say,
identified.
Lucy, if we talk about that in recommendations, use the time between now and recommendations to think of the specific things you would like to suggest that the committee writes to. That'll give you a bit of space to get your ducks in a line,
thank
row,
you.
whatever.
And it will be good to have specific responses to the people that have presented today as well. So I'll get my ducks in a row on that one as well. Thank you.
Thank you. Okay, the next person I have to speak is Stuart, please.
Yeah, thank you, Chair. And first of all, I'd like to echo the comments that were made around the public speakers and also the volunteer that has spoken around getting involved around his experience. It really is good that people are trying to shape the service. And to the first public speaker, I can't imagine what you've been through, but thank you for coming and sharing it with us. It is appreciated. In terms of my comments, and this comes from a position of having had the chair for children's services and having legal responsibility around that, I'm aware that any inspection by Ofsted or CQC is just a snapshot in time, and it is what point they come and look at your service. And it is around delivery, and it is around culture. However, our role is not to look at the areas where things have no doubtedly improved, and there are some goods. It's to look at the areas where they are still saying requires improvement, and there's needs in there. And when we look at those in the report, there's a number of areas that are quite concerning in things like mental health crisis services, mental health support for children and young people, acute wards for people of adults of working age, and long stay rehabilitation. So quite difficult areas. And when they look at culture of the organisation, not the service delivery, there are ones in there regarding learning, ability to learn as an organisation. So they're quite concerning areas that aren't, because this report covers a lot of ground, we really haven't got the information behind those around the plans, what is being delivered, and what the aspiration is or the drive to do that. Areas of concern for me in the report are that we've got the new FLO service, and we've previously had a briefing on that, which is fantastic. But the fact that they've engaged 120 families since coming in that have suffered some sort of trauma is a concern. What type of trauma are they supporting and how? And that we've just heard in this meeting around overdue serious investigations. We've had comment around that, and that they're trying to improve the situation on that. So the key thing for me, I'm wondering whether a recommendation that I would be looking to put forward around this is, can we have a follow-up briefing paper on all of those key areas of concern, covering those issues and covering the learning that has come out of them, so that we can actually check on the detail behind the oversight or the overview that we've been given here. And then one other question I've got is around structure. And this is a theme for me today, I think, as I mentioned it earlier on. There is a considerable amount of structural change going on in the ICB and in the county councils and the borough councils that's likely going to happen in the next 2 years. We've got a structure that's been put in place by the NFST that actually suits them around, this is our delivery area and these are the boundaries. quite clearly that may actually create a mismatch with the authorities that are going to be coming. And I'd like some reassurance that actually, in a time where everything is fluid, that there is that flexibility to change with partners. Otherwise, we might have a system that where central government's ambition is to actually make it that there are less barriers to sharing information and dealing appropriately. We might have one in here that is actually one of the core things stretching across Norfolk and Suffolk, might not align with the other parts of Norfolk and Suffolk. So I just want reassurance around that, but my recommendation will be that we actually ask for more detail in a paper around the areas for improvement. Thank you, Chair.
Stuart, will you do as I've asked Lucy to do, that is sort of write it out, and then when we come to recommendations, you can give it. Thanks very much. A response?
Yeah, please. Thank you, it's helpful. So in terms of, I mean, you know, whether we like it or not, the CQC are the regulator of healthcare services, and they don't just look at a snapshot in time, they look in detail at a whole period of information, and then they obviously come and test that out with staff, service users and leaders. But the data, the most recent inspection we've had, they asked for 122 pieces of information, so it's really, really detailed. And the areas you talk about, they haven't been back to inspect yet, so that's why they're still requires improvement. So our inpatient wards, for example, we're anticipating they'll come back this time. They've done in the last year 5 inspections, so our crisis services, which whilst they showed significant improvement, still requires improvement. Our adult community services have been rated good, again showed significant improvement. Our forensic services shown good with some outstanding. And then they've just been backed in the last month to look at our older adult inpatient services and our rehabilitation services. So we're waiting for the outcome of those. The improvement plans around any of that, we publish as part of our public board. But very, very happy to bring any detail back and follow through. In terms of localities, the reason we moved into the localities that we have was to be coterminous with other partners. So we have 3 localities in Norfolk and 2 in Suffolk. But of course, we all need to look together to see how we develop those in the future in light of any changes. Do you want to come in? Gary wants to come in.
Just one final point for reassurance, hopefully, Councillor. Last month, we had a joint workshop between the leadership team in NSFT and Ian Wake's team in the local authority for those very reasons, to work through what are their transformation programmes, what are ours, where we've got shared interest, where we've got some challenges we need to work together. And we've agreed we'll do a quarterly meeting on that, just so we can work together, because I think that's been one of the criticisms, is NSFT hasn't worked collectively with the system. Well, that's changing. We're going to have the same process in place for children's services as well. We haven't got the data range yet for Norfolk, and we're doing exactly the same with Suffolk local authority, both adults and children. So we should be in a position where we're working right across the system, not just with the local authorities, but ICBs, third sector providers. So it's a much more integrated approach.
Thank you very much. The next person, please, is Victoria.
Thank you, Chair. Thank you very much for the report. It's brilliant to see all the improvement that's been happening. I wanted to drill down a bit further, much as Stuart has done, and I would add another question. I had a quick peek at the performance report from the board, and I understand that there's a time difference. Obviously, that was from November, and you're reporting more recent data. But drilling down, for example, and they're not exactly analogous, I know, but look at specialist community mental health services for children and young people, which is rated as amber. And if you look at the metrics in the performance report with the eating disorders, I know it's not identical, it's just a proxy, but actually the numbers are possibly not quite as healthy as you would like to see them. And again, there's looking at the emergency acute access, and if you look at the crisis weights and the metrics that aren't meeting standards, and I think there's a lot of information in there that would be really helpful to cross-reference to underpin what you've been telling us, and then we'd have more confidence, I think, and more assurance in in what you're doing. And again, I appreciate that the timing of it is different, and therefore you might not, but it's the best that we can, the best I could find anyway, to see, actually to drill down. So my plea would be to have some more information accompanying any further briefing that would allow us to have some assurance. And if not, to make sure the trajectory to target was absolutely definitive. Thank you very much.
Yes, fire away.
Thank you, Councillor. I guess what we've done in the report is give you headlines. Of course, we can give some more information, and what we've really focused on in the last 2 years is across all our services reducing waiting times, and you can see that at a headline level. When we get into the detail of some services, for example, children's wait, and particularly with a neurodevelopmental delay, have been extremely high, and we've worked with Richard's team in the ICB and got some regional funding, hence why we are making and will make such progress by this summer. I'll ask Gary to come in. The eating disorders issue is a very small number of children, young people, but maybe you can just come in with that.
Yeah, I mean, really, you've covered that, but we're dealing with very, very small numbers. So if you do miss a particular time scale, then that percentage looks huge. But it's something we're aware of. We've got improvement plans in place, but we can just miss one appointment, and that can sometimes be 30% on my target. So, but I do exactly know where you're coming from. We need to get better at how we actually make sure we hit that target, because they are small numbers as well.
Thank you. The next person, please, is Paul.
Thank you, Chair. I don't know whether I missed something, but in the presentation was slightly different to what we had in our briefing. And I noticed that the waiting times, it flashed up for literally seconds and then disappeared, which is something I wanted to see. That was just before the QCQ ratings were on the screen. But I want to ask quite a simple question. I understand that new potential patients are being told they could wait up to 18 weeks before they would be able to see or have an in-person consultation with a doctor or similar professional, which is an awful long time to deteriorate. So is that correct, what being told?
So that's the national standard, and that's what's commissioned. So obviously one of the significant issues nationally is funding both for the NHS but also for mental health. Of course, our ambition is to see people sooner, and there's plenty of examples where we do that, but that is the standard across the country.
That sounds a bit complacent to say that's the standard. I mean, if that is the thing, we have a crisis.
Paul, there's no complacency, I can assure you, Councillor. But if we go back 2 years ago, it was way in excess of 18 weeks, as you can see from the data that's in the packs and that we presented. Of course, we want to reduce it, but we can only work, obviously, with the resources that we've got.
So that was what I was alluding to, that we are in a crisis because we are your service is underfunded, and I'm talking obviously to the wrong person about this because it is a national thing, and I think it's that bad here.
And Paul, just a point, I think where you thought there was variance, I think both the report and I think the slide said we reduced it by over 80% reduction. So I think there shouldn't be any variance in there, but we will check.
Okay, thank you. I'd like to ask a question now, with regard to funding, everybody in the country should be outraged about mental health, mental illness, outraged. It's an absolute disgrace. If the same figures were applied, I think, to physical health as are to mental health, well, there'd be far more of a scandal. Anyway, I'm off my soapbox now, and I'm here now to Thank you. I'm here now just to ask some questions. I know there's a lot of information about stuff to do with people who are seeking sort of mental wellness, but I'm very concerned about people who have mental health disorders, long-term mental health disorders, who are severely mentally ill. And I want to know, why was there insufficient evidence about long-stay or rehabilitation and wards for older people with mental health problems? Why was that?
I wasn't here at the time that the CQC did the inspection, councillor, but sometimes they decide that they're only going to come, and there's five overall themes that they look at, and sometimes they don't look at all five, and then they say that there's insufficient evidence. Now they've just come back for our rehabilitation services and our older adult inpatient services and have inspected those. So we will see an outcome for those two services, and we're anticipating that they collected enough evidence. Having said that, in our rehabilitation services, it's a very small service for inpatient. There's only 4 patients on a ward, and we had 4 inspectors. So you know, it's a very, very small service compared to our older adult services that have multiple wards. I'll ask Dr. Dalton to answer the first part of your question.
Yeah, thank you, Chair. And I do think it's important that we provide good services for people with long-term mental health conditions. There's very strong clinical evidence that having high-quality rehabilitation services reduces people's need for acute mental health care and promotes their recovery and well-being. National average is that there are 60 people per million population in rehabilitation services, whereas in Norfolk and Waveney we have a far, far smaller number, which means that we need to work and are now working on developing a strategy so that we can provide that high quality rehabilitation pathway for people. It isn't only going to be an NHS task, because a lot of those rehabilitation needs relate to social support, meaningful lives and jobs, and partnerships with the voluntary and community sector. And we've got a piece of work going on at the moment to develop that strategy. And it builds on some work we've already been able to do. So over the last 5 years, we've developed a community rehabilitation service that supports some of the population of Norfolk. But clearly it needs to be the whole of Norfolk and Waveney, and clearly it needs to be richer and more embedded in local communities, because a highly specialist service is only the right thing for those people who've fallen through the gap in terms of what needs to be in neighbourhoods. So we're looking forward to build something richer and more available where people live.
Thank you. I'm just going to do a quick follow-up on that. It just strikes me that the figures of people who have mental illness, you know, long-term chronic mental illness, they seem to be ridiculously small. And taking up the point that Councillor Corlett made about people within her division, all of us have people in our divisions who clearly have chronic long-term mental health problems. And I wonder sometimes if mental wellness is concentrated on more than people who are long-term mental health problems, because of all the, in the Cinderella service, they are really the proper Cinderellas, is what I would come back with. Anyway, sorry, I need to apply my own rules to this. Pallavi, please.
Thank you, Chair. Thank you for the report, and thank you to everyone who spoke today. I would just want to echo Brenda's comments about funding mental health. I think we all feel passionately about that. I don't know if a recommendation can be made that we write to say, how can you squeeze funding for a trust that's been in so much trouble and is trying so hard to improve matters for our local population. But it's just come from my other questions. I also want to echo what one of our speakers said, I think it was Natalie, about the care plans being written, but the actions not happening on the ground. I have not firsthand, but as a GP, I've seen that with my own patient, quite recently actually, where they were told that they could have patient-initiated follow-up within a certain period of time. When they tried to access that, the doors were just closed. They could not access that help. They came to see me, and I actually failed to get them in the door as well. I wrote, there was no response, and this was a person in crisis. There was no doubt about it. Her ex-partner cancelled all his plans and stayed, I won't go into more detail, but fortunately, a crisis was averted. It took up a lot of our resource within primary care and her family stepping in. So I just wondered, obviously you're a big organization, and I really appreciate that culture change takes time. And this is an individual person, but of course ultimately the work happens on an individual level. My question to you is, how do you know that this is happening? How do you keep tabs on it? And how are you going to remedy it? I wrote, as a GP, as the patient's GP, I wrote to the trust, and I said, this is unacceptable. This patient has been seen, and my letter was diverted to PALS. It just baffles me. What is the process here? Thank you.
Thank you very much, Councillor. So in terms of getting through when you've got a patient as a GP in a crisis, we've established in our 111 services the professions line. So it'd be really good to understand, maybe outside of here, if that didn't work, because obviously that's really, really important for us, and we've enhanced the practitioners to make sure that we've got more senior practitioners that are able to be responsive to professionals. We track, go back to where we started, we've still got variation, significant variation, and it takes a long time to turn around the services, as we've said. We track the percentage of patient service users that have a care plan and a risk assessment, and then Anthony, I'm sure, will want to come in and we do audits around that. And of course the CQC, when they came to our adult community services and our crisis services, looked at both, but we still got variation. Our PAL service is our complaint service as well, so that's our standard service, that if somebody is wanting to put in a complaint, that's the process that we have. But of course you can always escalate it up to any one of us, but I'll maybe ask Anthony if he wants to add anything.
Thank you, Caroline. And I'm really sorry to hear about that experience you've had, which is not good by the sounds of it. The issue I think that you're pointing to is continuity of care, and how do we ensure that when somebody's discharged that care plan is followed through. We talk a lot about quality improvement, but it is one of the areas that we're looking at in terms of our discharge, our safe discharge policy, and making sure that there is follow-up, there is timely engagement, and that the care plans that are agreed are followed through. We'll only be able to evidence that, in terms of how effective that is through our subsequent audits that we'll be doing around that. But it's certainly, an issue that we know the standard isn't good enough at the moment, and it's one of our improvement areas. Caroline sort of mentioned about how we've tried to improve the contact between professionals and our crisis service, but the continuity of care issue is something that the care plans is something that we monitor on a regular basis, and those audits, although they've improved, they've recently plateaued. But it is obviously something that we're focused on and determined to improve.
Yes, of course.
So I have a separate question about staffing. Really happy to read the percentage of improvements in regular staffing. Very, very happy to see that you're reducing your temporary staffing levels, that you have substantive posts filled. I think that's a real achievement, that, ultimately a service is, yes, lovely buildings are great, but ultimately it's the staffing that will make or break it. My question is, as a GP, I have very little interaction with your psychiatrists. When we write, for advice, or when we ask someone to be seen, they almost never seem to see a psychiatrist. We never get a letter back from a psychiatrist. We hear from the clinical pharmacist, and astonishingly, I've had advice on changing medication about whom this individual had never seen, no clinical assessment. The assessment was mine, and yet I was being given advice which I felt wasn't appropriate. I didn't follow it, but you know, the point is, it doesn't inspire confidence. Yeah, just wondered, is this your understanding as well? Do you find that your psychiatrist population has very little contact with clinical cases?
So I'll ask Dr. Dalton to come in a second. It's a really high priority for us, obviously moving to localities, moving to neighbourhoods. We've significantly increased our medical leadership roles. We have associate medical directors as well as medical directors, and we want to roll out much more broadly information, advice and guidance. So we'd want them, our psychiatrists, to be working closely with our GPs, but I'll ask Dan to come in as well.
Thank you, Caroline, and thank you for bringing this up, Councillor. It's absolutely critical from my point of view that not only are psychiatrists able to have those conversations with GPs, but that they're at the earliest point in a patient's journey, because actually I think all the evidence says that having the most expert individuals making the early decisions has the best impact on people's care. So as Caroline says, one of the things we've done is we have now a set of our consultant psychiatrists who are supporting the digital advice and guidance line, so that any GP can make a digital inquiry and have that responded to by a psychiatrist. That's been in place for the past 6 months, prior to which, as you say, it was pharmacists who would have responded. And I'm not diminishing the value that a highly expert pharmacist brings, but actually I think if a GP requests medical advice, it should be a psychiatrist that responds to that. So that's an offer that we now have. And we're working with our ICB colleagues to make sure that's as it should be, and hopefully can be comprehensive. But I also think it needs to be more than just a digital communication. What's really important is that we can, over time, arrange our community teams so that they align more readily to the way that our GPs work. And I'm struck by the comment made by your colleague earlier about how changing configurations and geographies over time need us to change and reconfigure what we're doing. So we are looking at reorganising the shape of some of our community mental health teams so that they fit with the shape of our community provision, so that there's that opportunity to build relationships, and we're starting to see that happen. But as Caroline says, it's an early stage in that process, but I would be really happy for the individual relationships to be strengthened, and keen to make sure we do everything we can so that you have that trust.
Thank you. Leslie, please.
Thank you, Chairman. You asked the exact same question I was going to ask about the insufficient evidence, and I found it confusing, because if it wasn't inspected, then perhaps it should have just said that. But I want to ask about the learning from deaths and safety governance. It goes on in that section to say that about family involvement, but is that before the death occurs, or is it as a result of death occurring? And is there a way that can be managed better? But I have another quick question as well afterwards, if that's all right. But I'll have that answer first, please.
I'm sorry, could you just repeat the second part of your question, please?
Well, it was about, it says on your page 8, leading into 9, that about families being involved, and I wanted to know if it was before a death occurs or as a result of a death occurring, and if it is as a result of death occurring, should it not happen more? I know that is not possible for all patients. I've come across people with mental health problems who have no contact with family and friends, but in some cases it may be that.
Yeah, okay. First part of the question was around the CQC inspection.
Well, you'd already answered it.
Yeah, I mean, we can't, obviously it's for the CQC to decide whether there's evidence or insufficient evidence. We have to publicise what their judgment is. So that's just the standard publication. It's not something we can tamper or alter with. Involvement of of families and carers is a really high priority for us. We are doing our best, and we still have a lot of work to do. And there's been significant issues historically, I think, with families feeling that because of confidentiality, they haven't been involved enough in the care of their loved ones. We've developed something called a common sense confidentiality policy. And then we've also developed a family liaison officer roles. And I'll ask Anthony just to come in to say a little bit more about that. Thank you.
Thank you. Yeah, so it's both. We need to be doing it pre and certainly post. But as Caroline says, we've got the common sense confidentiality policy. We've also just recently launched our carers charter and strategy. The triangle of care is essentially when somebody presents to our service, then our teams need to be ensuring that they're where consent is given, obviously, that we're liaising with the family member or carer. That's part of the triangle of care. So that's designed to ensure that people's ongoing care is done in collaboration with family or carer members. But certainly where there's a tragic loss of life, as Caroline's mentioned, we have our family liaison officers now in the trust that they came on the back of all the work that was undertaken around learning from deaths, and so they're our point of contact with families to support them through the process after a death has occurred.
Thank you. Can I just ask a quick question about the LIA?
Yes, of course.
You mentioned that there are going to be 7 new neighbourhood health centres. Is that enough? I always ask questions because if it's not enough, please say so, and then maybe the funders can look into that.
So I'd say it's nothing like enough. And we've had to have those 7 rank in terms of priority, but it's a really good start. So far, there's only a handful of neighbourhood health hubs that have been developed nationally and funded by NHS England in the last couple of years. So the fact we've got 7, I think there's only 4 that have happened so far in the whole of England. But that's all subject to funding, and that's only capital funding, so there'd be a lot of revenue funding that would be needed.
Thank you. There's a lot of talk about neighbourhoods these days and how input from local people and whatever. So those are important, aren't they? Good luck.
Members, can I ask if anybody has a second question? I know I do, but I want to let anybody else have a say. No? Okay. Okay. I just wonder if you can tell me what impact has the corporate teams restructure had on clinical services. I understand in particular that the reduction in resources for patient safety means that more clinicians are spending time on patient safety investigations, and that the reduction in human resources has resulted in staff investigations taking considerably longer. I was told that some staff have been removed from clinical practice pending investigation outcomes since 2023. Is this right, or is this wide of the mark?
There's quite a lot in that question. So in terms of our corporate services, that was something that we wanted to do anyway. When we restructured into our clinical services, we knew that our corporate services weren't working in the way that we wanted them to in terms of responsiveness in lots of different ways, and making sure we had the right quality. But then came a national imperative that every NHS trust had to reduce its corporate services, and that was a directive. But because it was quite helpful for us that we already wanted to do that. What we've done is we've restructured our corporate services so that all of them now face into our 5 localities, so that they're there to support our localities. We've got a lot of work still to do. We're still at the tail end of the changes. In terms of investigations, regardless of money or delivering efficiencies, we are absolutely clear that people in corporates, in clinical services, should be part of investigating and learning from things that maybe don't go as we want them to. And what had happened historically in NSFT is increasingly that wasn't happening. So sometimes external people were brought in to investigate, lots of corporate services investigating, and very little focus of clinical services focusing on, you might go to a service that you're not managing and investigate, and then you can bring a whole lot of learning back. So that's absolutely at the heart of our corporate services redesign.
Have people been waiting since 2023?
For what, sorry?
People have been removed from clinical practice pending investigation outcomes since 2023, is that?
I don't think they've been removed from clinic. There'll be absolute isolated examples where there's a whole context around that. But I don't think people have been removed for 3 years. However, a big part of the challenge of our corporate services would be an example of why those investigations haven't happened. And Anthony just talked earlier on around the investigations of serious incidents that, over decades have been very, very long, over the last decades. And by the summer this year, we'll have resolved that. So it's not at the same time, we've got a lot of work to do to make sure our investigations are timely. And we've put in our HR services now 5 business partners for each and teams for each of our 5 localities, and that infrastructure wasn't there before.
Were you attracting me, or did you have a twitch? Oh. Okay, thank you very much. Thank you. Okay. So we will move on to recommendations, please. And I'm going to start with Lucy. I think if you could speak fairly slowly so that Becky has to record all of these things. And if everybody else listens quite carefully to see whether or not you agree with it. So over to Lucy, please.
Thank you. I'm happy to repeat it. I've got a couple. Hopefully some of them might capture things that other people want to say. So committee notes that NSFT have been issued with a number of prevention of future deaths notices, sometimes with repeated themes. Once they've submitted their written response to a PFD, there's no external or national oversight of this issue, which is a significant gap in improving patient safety. This is not unique to NSFT, it's wider services, but it's a good illustration of a national issue. Our recommendation, well, I could liaise with the chair and committee officer on specific wording of a letter to ministers for circulation to the committee prior to sending, if you like. I mean, I suggest we take that as a work action to draft a letter to ministers about that gap. I've got a second one, if that one's clear.
Can I just check with Becky on that one? Are you happy with that one?
Councillor Jones, could we please come in?
You could. Let me just check with Becky.
Thank you.
Yeah, You've got that.
Yeah. So I'm not sure that's quite accurate. I just need to say that at this point. Historically, the Trust had very high numbers of prevention of future death notices. We haven't had those numbers now in recent times, which is why we've illuminated that in the report. The previous councillor was talking about the process. Obviously, there's an in-depth process that's used to look at every through inquest at every death, and the coroner decides, is there learning that the Trust hasn't demonstrated has taken place, and if the coroner believes it hasn't, then it gives the Trust a prevention of future deaths. We haven't had those now for since November 2024. I just wanted to clarify that. Thank you
for that. I mean, can I just say we can add historically, and so I think it's still a relevant issue for us to bring up as a HOSC. It's our role.
Can I? Yes, of course.
Thank you. So just to clarify, this is the proposal essentially is to write about that national oversight not being there. not necessarily a reflection on what's happened at NSFT, but the understanding that there isn't an oversight mechanism at a national level, and to raise that with the appropriate department. Is that what you're requesting, Councillor?
To say historically, that, I mean, we're not raising it in a vacuum. We're raising it because historically it's been an issue, and we don't know if it might be again. No one's got a crystal ball, so you know it's not a direct blame thing at the moment. But I think it's an important thing for us to raise as a HOSC.
Can I ask members, please? Do members have any thoughts on that?
Yeah, thank you, Chair. And coming from a background where in a previous life I was a senior identification manager working towards a coroner, with our regional structure of coroners and the decision being as to whether it should be put forward as a matter of learning from the coroner, there can be within the system various degrees of, we don't know whether there is learning to be had and it's not being put forward, or whether they're not being identified, or whether the system has changed with the coroners. So by having a national structure, at least you'd be able to see regional variations of what's being put up and what's not being put up. So it does need something above it, because at this moment in time, as a councillor, I don't know whether, you know, on the face of it, it looks an absolute success. We've had nothing for a number of months, but that could be that actually our coroners are applying the system differently. And until we had something overseeing that, we wouldn't know.
Pallavi, you have a comment?
Only to say, this is the sort of thing you'd expect CQC to be looking at, you know, within their inspection regimes. So I just wonder whether this should go to CQC as well as...
Chair, can I come in? I don't think CQC's got any influence in that area. I mean, from my point of view, I hear the conversation, but I think that the crux of your letter that year is about the national oversight. There are prevention of future deaths issued every day to mental health trusts, to acute trusts, a number of different organisations, local authorities, care homes, so primary care. So if the concern of the committee is about the national oversight, then that's where you need to focus it, because there isn't anywhere that are held. Some organisations do not even reply to a Regulation 28. NSFT has replied to every single Regulation 28 that's been applied, certainly that I'm aware of in the last 10 years. So I suppose it's just how you focus that question. It's really important, and not detracting from the views of NSFT, but this is a national issue. It's for any mental health trust in the 100 square miles or so will have had prevention of future deaths, as will other care providers as well. But I really take the point around the importance of getting the national oversight, because that isn't there.
Okay. So, Lucy, I think the thing that you were suggesting was that maybe we would get together, we would write the letter, we would circulate it to the committee and get the committee's permission to send it. Is that?
Thank you very much, Chair. Yeah, that is. And I just have a brief second recommendation as well, if that's okay.
Yeah, let's deal with the first one first.
Yeah, that's fine.
If we could.
Yeah, I think
so,
if everyone's happy with that.
Are people here? Oh, I need a seconder for that, please. Stuart Dark, thank you. Okay, now can I please have a show of hands? Those in favour? Anyone against? Okay, that one's carried. Okay, your second recommendation.
Thank you. So we've heard that a lot about safety data today, and it's obviously the core of things. I would like to hear responses to our speakers a bit more thoroughly from NSFT, but this is a separate thing. There's too often safety data is only published for wards, not community, I think is what's emerging. I think we want to be reassured as a committee on both. So I'd like to recommend that future data is collected, or I don't know how we phrase this as a HOSC recommendation, that future data is collected and shared that provides more information on patient safety, for instance, on deaths and harm in wards and community and during waits for beds from the point of view of assessment to admission. So harm in the round. Becky might be able to advise how that can be phrased as a recommendation.
Yeah, thank you. So, so if the recommendation is to put that explicitly to NSFT as a formal recommendation, if the committee were to agree that, then obviously I could send that on behalf of the committee to NSFT, and then they could formally respond to that recommendation, and that formal response would be shared back with the committee.
Chair, sorry, I'm not sure if I'm supposed to do this, but it may just be helpful in forming your questions. So we collect data of all incidents, whether that be community, whether that be inpatient. So if that's the information, the safety data covers all our services. Every service we provide, from talking therapies through to inpatient services and the most restrictive services. So we have that data, and we can break it down by community, by inpatient, whatever the question is being posed by the committee, just so we're absolutely clear. It's not we don't just collect information for inpatients, anybody who's under our care.
Does that answer your question, Lucy?
Yes, I'd like it still as a recommendation so that we can have that data then.
So the recommendation then is to request the information?
Yes.
Okay, can I have a seconder for that, please? Paul Neal, thank you. Can I have a show of hands for those in favour? Okay, that's carried. Thank you very much. Okay, Stuart Dark now, please, recommendation.
Yeah, thank you, Chair. And this come back, just to preface this does come from a point of, with the recent CQC inspection, that quite clearly an awful lot of work has gone on, and there are a lot of good areas. But actually in our role in HOSC is to actually look at the areas that require improvement. So I'd like, if I may, that there's two parts to this. The first part, and hopefully it's not much work because I would expect the Trust to doing this in any event, but briefing paper be brought forward to HOSC, giving the detail for each of the areas identified in the recent CQC report as being requires improvement, both in service delivery and organisational culture, and that this report specifically covers the Trust's action plan for each area and timelines, because I think that would give us reassurance of those areas that have been highlighted. And then the second part of this, and with regard to organisational learning, which is specifically one of those requires improvement areas, explains the methodology to systematically capture, assess and disseminate this. And specifically, given the high impact and associated concern, provides the data around deaths, both of service users and, if possible, those recently discharged, and support around families supported by FLOs following traumatic incidents, and any lessons learnt from these and how these lessons have since been embedded across the Trust. So there's two areas there. The first one is in general, can we have a look at the improvement plans? The second one is specifically around these high impact areas with the learning, explain how that's been done and how it's gone across the organisation. So I'd be looking for the support on that, if I may.
Thank you. Do I have a seconder? I have Lucy Galvin. Can I have a show of hands on that one, please? Those in favour? Thanks very much. Any more recommendations? Lucy.
Sorry, yeah, I mean, obviously it's a very big subject and we want to do it justice, and thank you for all your time and effort on it as well to everyone that's come here today. And I'm aware it's an ongoing one, so there are going to be recommendations. I just wanted to have responses to the issues raised today from the Trust as well, please. There was an issue around a workforce issue from Unison that was quite specific. It has been brought to HOSC. I do think we would like to know what the response given was quite a general one. So I think we've covered off the questions from Councillor Corlett and the staff safety, staff not trusting the organisation has also been covered, I think, and what Councillor Dark's asked for. But the workforce issues, I don't think we've heard really anything about, and it's probably too detailed to go into now. So would it be possible to have a briefing note updating on those?
I'm handing to Becky, who's desperate to tell us this.
Yeah, I just wanted to be clear that the committee can put a recommendation forward that you receive, that you request NSFT provide feedback on the issues raised, but it would be the committee that receives that. It wouldn't be a direct response to those members of the public who spoke. So just to be clear that the committee can ask for that feedback from the speakers today, if you so wish to do.
Yeah. Chair, could just, sorry to come in, but particularly on the unison issue, we're happy to provide an update where we are, but I mean, I'm not sure it would be appropriate given the, as a commission and provider, employer relationship there. So, but we're more than happy to provide an update where we are, but not get into the detail because that's going through various employment processes already. So it would be, I think, inappropriate to bring it here in its detail.
Thanks very much. Lucy, are you happy with the suggestions?
Yeah, an update on, I mean, you can listen back to what everyone said. I'm sure the speakers would also send you the information so that you've got it, but then a response on all three would be useful. Thank you. And
yeah,
obviously, don't go into confidential detail. I'm not expecting that.
We can do that. We can transcribe it and ask for that. Can I have a seconder for that, please? Can I have a seconder for that? Oh, Leslie, thank you. Can I have a show of hands, please, for those people who are in favour of that? Thank you very much. Thank you. Okay. Sorry, did you have a recommendation?
Thank you, Chair. Yes, only to say, could we just maybe write a letter expressing our displeasure of the cost-cutting impositions?
Okay. Yes. Yes, I'll second that one. Anybody who will write to the Minister for Health and see what we can do. Is everybody in favour of that? Yeah, okay, thank you. I don't know what it'll do, but before I go through things, I just want to say thank you to everybody that came here today. I want to thank the Trust because, my God, it's hard to keep coming back here, and sometimes I guess you must feel that all people do is criticise, and I think people are very aware of the fact that there are an awful lot of people who work for the Mental Health Trust who work night and day and are passionate about what they do. I, as a former mental health nurse, want to hear only good things about mental health, not how poorly funded it is and not where it fails. So thanks to the Trust. I also want to extend thanks to the other speakers who came today, the gentleman who came from Unison, and the people who sat up there in the gallery for their concern. Thank you so much. I know how hard it is sometimes to come to a meeting like this and to put things forward. I really appreciate it. And I'd also like to thank Emma Corlett, as always, because she is a passionate advocate for mental health and for people in her division. So thanks for all of that. Right, so we've done our recommendations. I'm just going to go now quickly through the things that people said. Stop me if I've got it wrong. Lucy spoke about transparency and learning from deaths and the current number of deaths and a timeline and what can we do about the coroner, which sounds like one person in particular, doesn't it? Okay. Stuart, concerning, he was concerned about crisis children, longer stay, patients, learning, trauma, overdue serious investigations, structural change over 2 years, and a possible mismatch in the future with all organisations changing and with the Trust's future plans. Victoria, who unfortunately had to leave us, was talking about a performance report and drilling down on specific details and asking for more information in other briefings. Paul was concerned about waiting times and the fact that there was just a quick flash of waiting times, but I think that was explained, and that new referrals can wait for up to 18 weeks, and that's a national thing. I was concerned about mental illness versus mental health, really. I think that sums it up, really. Pallavi, follow-up is hard to happen. Her experience as a GP is it's hard to get people in crisis some help, and an appreciation that culture change takes time. Speaking about staffing levels and praise for the improvements that have happened. And when she was concerned about how hard it is to get hold of a psychiatrist. Leslie wanted to know about learning from deaths and asked for clarification. And are 7 centres really enough? And I was asking about the impact on corporate teams that the restructuring has had on clinical services. Did I miss anything? No? Okay, thank you very much. So that concludes that part of. You don't have to be here if you'd like to go. Sorry, I didn't realise that I had to give you permission to go, but leave if you'd like to. The next part's very exciting. Okay, thank you. We're going to move ahead now with the Forward Work programme. Oh, Michael, could you just stay for a minute, please? Or could you come back afterwards, please? Thank you. Thank you. I'd like to invite Becky, the Democratic Supports and Scrutiny Manager, to introduce the Forward Work programme that you have on your agenda. Becky, can you provide the committee with an update on where we stand with the scrutiny of the Vulnerable Adult Service in
Thank you very much, Chair. So to introduce the report, you've got the draft forward work programme in front of you as Appendix A in the agenda pack from page 90 onwards, which pulls together the proposals that the committee has previously agreed in terms of reports and briefing notes. I'm happy to provide the committee with clarification on where we are in terms of the Vulnerable Adult Service or the Health Inclusion Hub as a committee. You will recall that shortly before the last meeting, the Chair and I were alerted to what was at that point being described as a possible Secretary of State call-in request of the Vulnerable Adult Service contract. At the time, it was suggested the committee might want either an additional meeting time or an extension to a meeting to consider the issues that were being raised through that call-in request, which members agreed to at the last meeting. Since then, we've sought clarification about this, and our understanding at present is that it is not, in fact, a Secretary of State call-in request, but relates instead to a challenge connected to the procurement outcome. And in that context, the committee is not the decision maker on the procurement process itself, although members may still wish to consider appropriate scrutiny activity. I've been liaising with ICB colleagues about what further information they can appropriately provide to support members in deciding any next steps. And we've got Richard with us here who can provide an update from the ICB's perspective. Members will need to consider and agree how you want to approach this item from here on in. And you've got several options that you could consider. So you might want to note the clarification and return to the scrutiny of this item on the forward work programme. You might want a formal factual update on the issue from the ICB, which the committee could request and could be circulated. And the committee could still want to convene an additional meeting to scrutinise the matter. Members would need to be clear what they wish to scrutinise and would need to agree to hold that again, as it would be a decision to hold an additional meeting based on revised information. So that's where we stand, Chair. Thank you.
Thank you very much. Thank you very much. Richard Watson, representing the ICB, will give us an update here. Are you happy for me to invite him to speak quickly, briefly?
Yeah, I'm not sure it's a huge amount of an update, Chair, but I can just say a few words. So I think, as Becky's already said, we're still in the middle of a procurement process. We're in the standstill in relation to the health inclusion procurement. And as a result of that, there's not a huge amount we can say because we're in that process. We've extended the existing contract and people are continuing to use the service. But as I said, we're not able to say more about the procurement itself until we reach a conclusion one way or the other. So we're happy to go whatever, as you've just outlined, Becky, we're happy to go with whichever way you want to go. But if we want to go into the detail, there's not a huge amount we can say until we've concluded this. And we can't put a precise timeline on that until we've gone through that legal challenge that Becky's alluded to. So whether we want to put it on the forward plan for the start of the next calendar year, January, February, March, sometime around there, and then we can bring it forward as soon as we're out of that procurement process.
Are members of the committee happy for that suggestion that it gets put on the forward work programme? I can see Lucy shaking her head.
Did you just say, sorry, yeah, I responded. Did I hear it right? You said the next calendar year. So if we put it on a forward work programme for the next calendar year, what I understood happened was there was a procurement, the contract was let, and then it's been challenged legally. I've just heard that now. I didn't have the benefit of any of that information in advance. And I haven't really had the benefit of any information on this, to be honest, which does seem problematic from a HOSC point of view. So I would like a briefing note on it, written down, I think, and then we perhaps take a decision. But I do think a year is a very long time, considering these are really vital services that are on standstill at the moment. How the staff coping? How, I don't understand how services can be delivered if you don't know who's delivering them or have any plans.
Would you like me to come back on that, Chair?
Yeah, if I could just say beforehand, Lucy, nobody knew before you knew. I didn't know before you knew. Yes.
So, to some extent, all I can say again is we're in a procurement process. We're at standstill period. There has been a challenge has been announced. I can't say any more as you would expect me to at this point. We can absolutely, you can put it on the forward plan for whatever month you wish, but until that standstill period and that challenge has been determined, we can't put an approximate date on where we can have that fuller conversation. We can absolutely provide you with a written briefing to the level of information we can provide, absolutely. And as I said, the service has carried on. So we've extended the existing contract, is my understanding, but we can't enter into a new contractual arrangement until we've got through this procurement process. So I'm as frustrated as everyone with this, but that's the process that we're in. So this is not that we're trying to be difficult, but we have to get through that before we can give you the level of information that I think you would like.
Thank you. So for our purposes in planning, it would be important to know what your horizons are then. So how long does the standstill process likely to last? There's presumably some deadlines or horizons you're working to. And if we know those, we can.
The advice I've been given by our procurement team is worst case, we would be looking at the start of the next calendar year. So if I tell you September, that's fine. We can put it on. But if we get to nearer that time and we're still in this process, we're going to have the same conversation again. So to some extent, I don't mind, but I cannot give you everything that you would like until we've exited that process.
Okay then, so we'll try and put it on the forward work programme for the beginning of next year, but if we could have a note, that would be great. Are people happy with that?
Yeah,
hang on.
September,
yeah.
Yeah, so just for clarification, because on the draft programme as it stands, the update is on there for the September 2026 meeting on this service. Do members want it to stay on there for then review, obviously, if we get to July, or do you want to move it to the early part of 2027? I just want to make that clear for the next publication.
Chair, would it be possible to keep it there for September? It would seem prudent because we're obviously not clear whether there may be information then.
Yeah, are the committee happy for it to be on September and then we can always bump it forwards if... Yeah, okay, thank you. Yeah, we'll do that. Thank you. Anything else for consideration for HOSC? Yeah, Leslie. Oh, gosh, everybody. Okay, Leslie, could people just say it quickly?
Queen Elizabeth Hospital is going under the National Provider Improvement Programme, which lasts for 6 to 9 months. Maybe we could have a brief report on that. I mean, my experience as a school governor, when you get help like that, you can do quite well. Because it was 134 out of 134 in ranking hospital trust.
Okay, thank you. Yes.
Yeah, we can certainly look to get a briefing note on that if members would like it.
Later down, it doesn't have to be next week, does it? Because if they haven't started
I mean, it won't be next week.
No, I know, I'm a governor there.
Yeah, no, we are getting regular updates from the hospital group. and obviously we're feeding them through to the wider committee. The item that you've got, actually the report from the hospital group update, which was originally going to be July, the proposal, as you've got it, is to move it to November because the National Outcome Framework data, there'll be more of that data available for the committee to receive and scrutinise. But in the meantime, I'm happy to speak to colleagues at the hospital group and ask for some specific information about the QE.
Thank you. Justin Court, please.
Thank you, Chair. As discussed in some emails with yourself and Becky, very grateful for your responses. I'd like to suggest we call in the Right Care, Right Person pathway, which has now been implemented and is well underway. I think it's about time we were able to bring it to HOSC. It overlaps with multiple physical health issues and areas, ICBs, mental health services, local hospitals, unfortunately the police as well. And I've spoken to Becky, I know there's some overlap there, some questions that might be asked, but if we could bring that forward.
Becky's going to say.
Yeah, so obviously it's appropriate for this committee to consider. As you've said, Councillor Court, there is an overlap with the police and we have to be aware that there's a scrutiny body for the police as well. So what I would suggest is the committee receive a briefing in the first instance on Right Care, Right Person, and from that determine how to take that forward. And in the meantime, I can liaise with colleagues in the Office of the Police and Crime Commissioner and see what that looks like as a scrutiny piece.
Anybody else? Stuart.
I hope you just don't mean, Stuart. Yeah, just very quickly, it would be unfair of me to put anything on the forward work plan because this is my last meeting of HOSC as I'm standing down at the election.
Me too.
So just for the minutes, because there's no any other business, can I thank you, Chair, and can I thank all of my colleagues at HOSC, and also for Becky for keeping us in good order and making good minutes out of sometimes difficult conversations that we have. It's been really helpful, and Megan as well, obviously, and all the officers involved in this. But I just wanted to have that on the minutes. Thank you.
I'm going to give you a virtual hug. Mwah. Okay, and Pallavi, finally, quickly.
Thank you, Chair. Just very quickly, the Steam Cafe in Kings Lynn has shut down, and I just wondered if we could keep that on the forward work programme to get an update regarding, the new provider, please.
Yes. Yeah, so with the Steam Cafe closure, we've been advised that there should be a new provider coming in, but then there's a wider piece of work that the ICB is going to be undertaking under the new ICB geography, which will cover that service and others in Norfolk and Suffolk. So if you're happy for me to sort of go away and bring something back as a briefing in the first instance, and like you say, keeping on top of what's happening with the Steam House Cafe itself, and updating the committee.
And just one final thing, Chair, if I may. This is Brenda's last meeting as Chair, and I just would like to propose a vote of thanks. As Vice Chair, it's been a real privilege. It's been really good. I've learned a lot from her, and I hope we've all agreed that this has been a good experience being at HOSC. So, if someone could second my proposal. Thank you.
Thank you. Finally, before the meeting ends, and the meeting is going to end, I asked Michael Chenery to stay here. I've been fortunate to be the chair of HOSC. When I started here 9 years ago now, Michael chaired this meeting, and I have to say I am standing on the shoulder of a giant. He taught me how to be kind, considerate, and inclusive. He's the most excellent chair of HOSC, and I wanted to express my formal thanks because he's a good all-round old egg. No, those words. An all-round good egg. Thank you very much. Anyway, the meeting's ended. Go in peace. Thanks a lot.